What's that?
Would you like me to get everyone's attention and introduce you?
Yeah, that'd be cool.
Good morning. Hello. Hi. Can you hear me? If we can go ahead and get started, I would like to introduce you to Dr. Ellis. He's our host today.
Thank you. I'm Jimmy Ellis. I'm a medical oncologist with LCMC. And welcome to the supportive care block. I want to thank everyone. Can't hear me? Okay. Do you know how to? Do I need to be closer? Or do I want to use that one maybe? Yeah. Oh. Okay. Is this better? Oh, okay, good. All right, so this will work. And I just want to thank everyone for attending. I also want to thank our friends and colleagues from industry who make all of this possible. Your sponsorship allows us to put on this meeting, and the tools that you provide us we use in our clinics. So this morning we have 4 presentations from some really outstanding clinicians. But before we get into the educational part of the talk, I'm going to do a couple of things. First, I'm going to give a definition on the scope of supportive care in oncology, and then talk a little bit about advocacy through the prism of supportive care. So CAGLA has 2 missions. We have an educational mission, and we have an advocacy mission. This year, we have a 3rd mission, and that's to help Chad Landry get in the Guinness Book of World Records for sending the most emails. And it's looking pretty good. The video will be sent to you as soon as he wins it. So let's go ahead and start with the definition. So the Multinational Association of Supportive Care and Cancer defines this as supportive care in oncology is defined as the prevention and management of the adverse effects of cancer and its treatment, including management of physical and psychological symptoms and side effects across the continuum of the cancer trajectory from diagnosis through treatment to post-treatment care. So it's a big definition. So let me throw a couple of questions out at you. What percentage of cancer patients need supportive care? 100%, exactly. And then for how long will our cancer survivors need that supportive care? They'll need it for life. And I think one of the wonderful things that's happened in oncology in the last 10 years, people are living longer, they're being cured, we're able to administer care with less toxicity, we're able to help people become whole after cancer, so survivorship is increasingly important as we go forward. I should have done slides. So anyway, supportive care is broad and holistic, and the way I would define it, if the body of work that is healthcare, supportive care is our connective tissue. It's our structure, our skeleton. It holds everything together. And when supportive care is deficient or absent, outcomes suffer, patients suffer. So in 1907, the physician Paul Ehrlich came up with the concept of the magic bullet. And the magic bullet would be a medicine that specifically and efficiently targets a disease without harming the body. But we all know that very few diseases have such wonderful remedies, and certainly cancer does not. What we do with healthcare is try to find ideal approaches, optimal approaches, things that achieve the goals of eradicating a disease and doing so in a manner that patients' quality of life is good and that they can return to being whole. The challenge in oncology is this. Our therapies have very complex toxicity profiles, and we have an arsenal of medicines and an army of people designed to help administer those medicines and get people through. And so that's kind of where we are today on the cancer side of, or in the oncology world. So on to advocacy. So in our healthcare system, advocacy is driven by economics. There's no credible person who denies the value of the care we deliver, but there are people who will deny you coverage. And if we can't get coverage for something, we can't administer it to a patient. And why is this in American healthcare? Well, we have things like prior authorizations, copays, deductibles, and denials. They should be lumped into what I call rationing. American healthcare is rationed. Some people get it all, some people get nothing. And I think that where advocates are right now is trying to help all Americans get what they need in a cost-effective manner. So why is this such a big problem in supportive care? The thing is that supportive care is human resource intensive. It's dependent upon direct provider interaction. And for some reason, our system doesn't reimburse that the same way it reimburses other things. So if there's no reimbursement, hospitals and systems will not allocate resources to those things. They will not develop programs. They won't go out and hire people to do it because they're not getting paid for it. The other thing on a global scale is that young professionals who might choose a career will say, well, you know, if I can't get a job, why would I study this? And so as such, we wound up with tremendous deficiencies in certain types of specialties. And actually, the one that's very personal for me is mental health services. So both one of my daughters and my soon-to-be stepsons are both mental health professionals who do amazing work with cancer survivors. My daughter's a trauma specialist. The problem is people don't want to pay for that. So we have to fight for those things. And so how do we do advocacy in America right now? Typically, we do it legislatively by writing bills designed to require coverage for things. And it's kind of a piecemeal approach. The problem with that is, while it is meaningful, we make very small steps. We can't get more global successes that way. And on the state level, even when you get legislation passed, maybe only 15 or 20% of people actually benefit. So what I'd like my take-home messages on advocacy to be is that meaningful improvements in American healthcare will require fundamental changes in our system enacted at a federal level. The focus of American healthcare needs to be keeping Americans more healthy, from preventive medicine to the treatment of disease to survivorship. And that's going to take, that's a heavy lift. And that's why when you are ever involved in something with advocacy, you need to make sure you know what people are fighting for, and we need to also work together. One of the things we see in advocacy is a lot of individual groups working independently. It's actually going to be better if we learn how to work together. So that's my message on advocacy, and we're going to move on to the educational component. So this is my 5th year chairing the supportive care block, and every year palliative care has been part of it. And this year we have Dr. Sonia Malhotra, who's an adult and pediatric palliative medicine physician at Tulane University, and she serves as the Associate Chief of Palliative Medicine. Dr. Malhotra is internationally known, holding a faculty position at Manipal Academy of Higher Education in India. She's won numerous awards for her clinical, educational, and research services. And most importantly, she's a wife and mother to 3 boys. So Sonia,
Thank you all so much. Good morning, everyone. Oh my God, that was pathetic. Good morning, everyone. Good morning. Palliative care is not depressing. I'm not a depressing person, I promise you. And so I'm gonna have you wake up and really sort of pivot off of what Dr. Ellis said. We need better advocacy. We need better supportive care for all of our patients all across the country, all across the world, and especially in our region where we are really struggling with cancer as a diagnosis. So this is the Pharmacist CE Learning Objective. So you pharmacists in the audience, you can get credit. As Dr. Ellis said, I lead palliative care services at Tulane School of Medicine, which encompasses University Medical Center, New Orleans, right down the street, and East Jefferson General Hospital. So I lead both of those programs, and we provide comprehensive palliative medicine services, inpatient, outpatient, and we are relaunching our inpatient hospice beds as of Monday. I know some of you all are looking at me saying, oh my gosh, she's a little bit young to be doing this. I promise you I'm not. I promise you hair dye is like the greatest invention in time that helps us stay and look young. But today I'm gonna talk about inpatient and outpatient palliative medicine pearls for the oncologist. Whether you're a physician, an advanced practice provider, a social worker, you're gonna learn some techniques on how to do palliative medicine well. I have no financial disclosures. So today I have 2 objectives: to define palliative medicine versus hospice care and end-of-life care, and number 2, to describe several approaches to pain and symptom management that the oncology practitioner can utilize. So I would be lying if I said that this cartoon is not what I felt like 11 years ago when I came back to New Orleans. So I had done my residency at Tulane in internal medicine and pediatrics, and I saw the care of patients living with cancer done very poorly. And especially when they reached end of life, those conversations were not happening. And I saw so many patients die in an ICU setting that I thought could have died at home alongside their loved ones. I will also say that I saw kids, because I am a pediatrician as well, children in the NICU and PICU settings, where quote unquote nothing could be done. Die alone, and there was something we could do. We could provide comfort even to those children when there was no other medical intervention that was left to be offered. So I'm glad to say in 11 years, when I came here, 3 of us were fellowship trained in the entire state of Louisiana. I was the 3rd one brought over from my fellowship institution at the University of Pittsburgh. There were 3 of us in the entire state of Louisiana. We now have about 20 palliative medicine fellowship trained physicians across the state. So in the period of about 6 years, we've been able to double that, and certainly in 11 years, we've been able to more than triple that. So this is a field that's growing, and we need it to grow. So what Dr. Ellis says comes true is we're advocating for patients and everything that encompasses their holistic care. So what is palliative medicine? You may wonder this. So the Center to Advance Palliative Care is our governing organization. And the Center to Palliative Care defines palliative care or palliative medicine as the care of anyone living, and notice I said living, with a serious illness. My patients are not all dying. And I want to stress that. Palliative medicine is the care of anyone living with a serious illness, and that includes advanced cancer. And you may wonder, what do I do? Because I'm an internist, I'm a pediatrician, and I'm a palliative medicine doctor. I am not an oncologist. And so what we do basically is in 3 major domains. Number 1, pain and symptom management. So any symptoms that affect the quality of life, those are things we're taking care of. Now, Dr. Ellis said his son-in-law and daughter are both mental health professionals. I'm a little bit biased about mental health because I married a psychiatrist. We can manage anxiety and depression. We can manage pain. We can manage nausea and vomiting. Any symptoms that affect the quality of life, those are things that we're helping to take care of. The second component is communication around the serious illness, whether that is goals of care, next steps in treatment, whether that is advanced care planning, any of those things that encompass communication. Oftentimes, I'm messaging doctors when the plan looks very unclear. If a patient's hearing 2 different things from 2 different clinicians, sometimes we as palliative care teams have to step in to bring cohesion to the team. The third thing is emotional support for patients and their caregivers living with serious illness, right? Because caregiver support is vitally important. And so I have an LCSW who does therapy with our patients. She does cognitive behavioral therapy. She does dialectical behavioral therapy with our patients who are living with serious illness and their caregivers. She's also able to do bereavement support. So when patients die, she is taking care of their loved ones. And then the last tenet, which I know some of y'all thought was the only thing I do, is what is called hospice end-of-life care comfort care. I can do hospice end-of-life care comfort care very easily. However, the joy in what I do in my career is actually the first 3 things: taking care of seriously ill patients and ensuring that they're comfortable through every stage of their serious illness. So, palliative medicine is the care of anyone living with a serious illness. We take care of patients and their families, and we manage any symptoms that affect the quality of life, communication, emotional support. And when patients transition into that phase of dying, we're able to manage them. Now, you may wonder, well, which hospice do you work for, Dr. Malhotra? I don't work for any hospice. I have no ties to any hospice. I am not a hospice doctor. When patients and families are ready for hospice, I can refer them to a hospice agency, and it's very deliberate. Our team is not affiliated with any hospice because we want to see patients upstream in the care of their advanced cancer. So we're a continuum of care offered with curative and life-prolonging treatments. I led the Ochsner Palliative Medicine program for 2 years, from 2015 to 2017. And I had a clinic called the Adolescents and Young Adults with Cancer Clinic. And there I saw kids with ALL. Does anyone know what the cure rate for ALL is in the pediatric population? 85%. It's actually 98% cure rate. And I saw each and every one of those children and young adults. And am I wrong on that? Somebody to correct me if I'm wrong. That's the last numbers I looked. Now, in the adult population, ALL is about 50 to 60% cure rate. I would see each and every one of those children and young adults during their cancer treatments, because cancer treatments create symptoms, and I would help to manage those symptoms. I just saw a man with prostate cancer in my clinic on Tuesday afternoon and graduated him from clinic. He is essentially cancer-free. We've weaned him off of his opioids. He has now graduated from palliative medicine clinic and will be managed by his oncologist and his primary care clinician. So what symptoms can we manage? The Medical Education 101, my master's is in medical education. This is the number one thing they say: don't put up a busy slide. And I promise you, this slide is busy intentionally. It's to show you the breadth of symptoms we can help to manage, the breadth of communication challenges we can help to manage, the emotional support, and then the continuation or coordination of care we can provide. In this lecture today, I'm going to focus on pain management and nausea and vomiting, because these are the top 2 symptoms that palliative medicine clinicians take care of when working with patients living with cancer. But as you can see, constipation, anxiety, depression, fatigue, poor appetite, dysphagia, delirium, dyspnea, secretions, end-of-life care, all of those symptoms are things that we can help to manage. Moving forward, which patients benefit from palliative medicine? This is the money question, because we're taking care of any patient living with an advanced illness. And so we can't see each and every patient. So we have some guidelines around that. Patients with advanced or serious illness that may have symptoms or communication challenges. There are a few tools for prognosis that you can utilize to see if your patient would be appropriate for palliative medicine. ePrognosis.com is a tool out of University of California, San Francisco, that allows you from the inpatient side or outpatient side to put in certain variables, and it will spit out a 1-month, a 3-month, and a 6-month morbidity and mortality ratio. ePrognosis is very helpful. If a patient has less than a year to live, they probably are appropriate for palliative medicine. For those patients with CHF, or congestive heart failure, or COPD, we're looking at either New York Heart Association class 3 or 4, or gold staging 3 or 4. This basically means that the patient is symptomatic from their primary illness. Now, ASCO, the American Society for Clinical Oncology, is the only society that has committed to every patient with metastatic cancer should be seen by palliative medicine within 8 weeks of diagnosis. So those are the ASCO guidelines for palliative and supportive care. The surprise question is a question that basically says, would you be surprised if your patient died within a year? If the answer is no, I would not be surprised if my patient died within a year. That patient is appropriate for palliative medicine services. And then complications from their serious illness. In our clinic, we do take patients who are living with sickle cell disease for the hematologists in the room. And those patients have to have complications of their sickle cell. If they have CVAs, or they have MIs, or the bone infarctions, we will see those patients in our clinic. So what does it boil to? Like a good gumbo, you have to have the right ingredients, right? You can't make a good gumbo without the right ingredients, and that's the same thing with palliative medicine. If you don't have the right funding mechanisms to be able to support a palliative care team, because we're not a money-making machine for hospitals, right? We probably save hospitals money, but at the end of the day, medicine in the United States is a business. And what people are looking for is revenue generation, not revenue savings. So it really does depend on what your hospital system is willing to fund. And most palliative medicine programs are inpatient-based, hospital-based, rather than clinic-based. Some are only in the cancer centers, so they're not seeing other patients with serious illness. And outpatient palliative availability then limits the ability for our patients to receive advanced symptom techniques like Suboxone, methadone, therapeutic marijuana, and then also for palliative medicine clinicians to be able to see patients that move from active cancer treatment into the post-active cancer treatment period. So again, another graphic to show you that palliative care is the care of anyone living with the serious illness, and we generally like to see patients when they are symptomatic from their serious illness. Now, I would be a fool if I said I could see every child with cerebral palsy, right? Adult palliative medicine clinicians are very few and far between. Pediatric palliative medicine clinicians are even fewer and far between. Yet I do like to see kids who are symptomatic from their primary illnesses. Hospice care, when appropriate, essentially, according to the Centers for Medicare Services, requires that a physician prognosticate that the patient has less than 6 months to live. If your patient lives past 6 months, they will not be kicked off of hospice services. The hospice has to demonstrate that there is decline in the patient's care. So I describe hospice to patients and families as when we have done everything we can in the hospital or clinic setting, and there are no further medical interventions to offer, we would recommend hospice care to limit the back and forth to the clinic and to the hospital setting. It's generally when life-prolonging treatments are not an option, back and forth to the hospital is not desired, keeping in mind that home with hospice requires a caregiver. Hospices only come in for about an hour, 3 to 5 days out of the week. So the rest of the care is then dependent on the family. Artificial nutrition and dialysis can be provided for while on hospice. There are just certain stipulations around that, how it is provided and how it is paid for. Hospice is a philosophy of care and it's an insurance benefit. Now, Medicare and Medicaid provide hospice services for every patient. Private insurances are a little bit tricky, and I'm actually working with LCMC Health right now to get our hospice benefit provided for our clinicians because private insurances choose whether the hospice benefit is active or not. It is an interdisciplinary model, so they do have social workers, physical therapists that can come and see patients, and the focus is comfort, maximizing time outside of the hospital or clinic setting and really focusing on what the patient's values are. However, people like me who like to see our patients when they're on hospice care can continue to see their patients on hospice care. So you all as oncology clinicians could still follow up with your patients even when they are in hospice care. So here's a case example. You are caring for a 67-year-old woman with lung cancer with metastases to the brain who was recently stepped down from the stroke ICU, who had a severe MCA stroke with midline shift. The family decided not to pursue trach and peg and instead compassionately extubated the woman who is breathing normally and without distress. The patient has comfort medications including IV morphine, IV Ativan in place should she require anything for pain, dyspnea, or agitation. Family has reported that they cannot take care of the patient at home. You ask your palliative care colleagues who have been following the patient in the ICU side to evaluate for inpatient hospice. Is this patient appropriate for inpatient hospice? What do you all say? Oh, goodness gracious. I'm sorry, y'all. This patient is not appropriate, and the reason being is they are comfortable. So unfortunately, CMS also tells us that it's not enough to be dying. You gotta be dying with symptoms to qualify for inpatient hospice. So patients who are comfortably dying, no active symptoms, do not meet criteria for inpatient hospice. You have to have active symptoms managed likely with the use of IV medications to qualify for inpatient hospice. Now, inpatient hospices can also provide respite care, which is a period of several days that the patient can come in and be provided care. And yet, they still have to be, to qualify for inpatient hospice, you have to be actively dying and symptomatic. Okay, and keep in mind in the New Orleans area, we have 2 inpatient hospices, one at Passages, or known as the Sanctuary, the other one at St. Joseph's Carpenter House, and then several of the hospitals have what is called inpatient hospice beds. Now, if this patient becomes symptomatic, where she's breathing 30 times a minute, her heart rate has increased into the 130s, and she's required boluses of IV morphine or IV Ativan, is this patient now appropriate for inpatient hospice? Yes, absolutely. So keep that in mind because that's a question that comes up quite a bit. I'm going to move forward to outline some strategies for symptoms commonly seen in patients living with cancer. And I'm going to focus on pain and nausea, vomiting as the two major symptoms. So when we talk about types of pain, I like to define pain in 4 broad categories. Number 1, of the nociceptive type, because your whole body has nociceptors. Your visceral hollow body organs, like the liver, have nociceptors on them. Also neuropathic pain, because our nerves can also create pain. For anyone who's pulled a nerve or pulled a muscle, that you get that, right? Bony musculoskeletal pain, and then my least favorite category, the other category, which consists of chronic and/or psychosomatic pain. Now, generally, cancer-related pain is of the nociceptive variety because cancer produces inflammation in the body, and those inflammatory mediators stimulate the nociceptors in the body to stimulate the pain response. Now, when we use opioids, opioids are appropriate for cancer-related pain. We need to use equianalgesic charts, and many of your institutions are on Epic or another EMR where you can use an opioid equianalgesia converting table. What this means is that everything can be compared to oral morphine. And we think about opioids as either same as oral morphine or more potent. And just a spoiler alert, if you look at this chart, everything is more potent than oral morphine, okay? What this means is 1 milligram of IV Dilaudid does not equal 1 milligram of IV morphine. When we look at this chart and compare IV Dilaudid right here, 1.5 to 30, that's a ratio of 20. So 1 milligram of IV Dilaudid actually equals 20 milligrams of oral morphine. And even when we look at oral Dilaudid to oral morphine, 30 divided by 7.5, 1 milligram of oral Dilaudid is equal to 4 milligrams of oral morphine. So why is our community so scared of morphine? We need to know this data. We need to know these charts really well because we need to destigmatize oral morphine in our community's use. People are okay with using oxycodone or Dilaudid, and they get freaked out when it comes to morphine. We need to destigmatize this as clinicians taking care of patients with cancer. So what this means is 1 milligram of IV Dilaudid, actually when we compare it to IV morphine, 10 divided by 1.5, 1 milligram of IV Dilaudid is actually equal to 6.67 milligrams of IV morphine. Y'all, we gotta destigmatize morphine to our community. And we need to make sure to do that because I hear that concern all the time. So many of our patients use opioids around the clock, short-acting opioids. When should we add a long-acting? Generally, when patients are using more than about 30 to 50 oral morphine equivalents in 24 hours, I like to add a long-acting. And what I do is I take the full oral morphine equivalent in 24 hours, and I multiply that by 2/3. And that gives me the dosing for the long-acting opioid. And generally, I'll keep the short-acting opioid the same, or I'll double it, and just making sure that your patients with cancer, oftentimes they need something that'll get their pain that's kind of going up and down like this, more steady state. That's the best time to add a long-acting opioid. There are other opioids, including buprenorphine or Suboxone, if you all have heard about this. We do use these in patients with cancer, living with cancer. And often we use them in the patients who have a history of opioid use disorder or substance use disorder. And the X-waiver elimination basically allowed any one of us who can prescribe be able to use buprenorphine in the management of cancer-related pain. Methadone is actually a phenomenal medication for patients living with cancer who have really bad pain. There is a role for its use in those patients who have opioid use disorder or substance use disorder, and it's also better for neuropathic pain. So if you've got a patient who has a highly innervated area that has cancer in it, we often will use methadone. Coming to mind are my patients living with cervical cancer. They often have very bad neuropathic pain and very bad nociceptive pain. Oftentimes they're using so many opioids that I have to switch them over to methadone as their long-acting pain medicine. We use methadone independent of methadone clinics. Methadone clinics are only for opioid use disorder. When we're using it for pain as clinicians, we just use a twice daily or 3 times a day dosing. There are some newer modalities for pain control coming out that I wanted to mention. There is this medication called suzetrigine or Journevax, which basically targets the sodium channels in the peripheral nervous system. It inhibits pain signals from reaching the peripheral nervous system. This medicine was studied in post-abdominoplasty patients and bunionectomy patients. Very drastically different patients, right? You're getting a bunion removed in one patient population and you're getting your belly cut open in another. So I don't know what to make of this medication except that it is really expensive. It had some data that showed it works, and yet it's $15 per tablet, which I don't think is very cost effective for most of our patients. So it's not a medicine that's being used. I will tell you their representatives are contacting me on a weekly basis. So it is coming up to a lot of clinicians. Just keep in mind from a cost effective standpoint, it's not very cost effective. And then virtual reality, right? You may see your aging populations using these cool glasses. Virtual reality as a mode of distraction and neural reprocessing is being used more in our patients living with cancer to basically help with their pain. Now, adjuvant agents are really important. Even when your patients are on opioids, they need to be on adjuvant agents like your gabapentinoids, like your tricyclic antidepressants, like your SNRIs to help with the neuropathic pain. And so my theory on use of neuropathic pain agents is hit 2 to 3 birds with one stone. If your patient's having trouble sleeping, use a TCA so they sleep at night and their neuropathic pain is controlled. It may also give them some anxiety and depression relief. If they have anxiety or depression, use an SNRI, right? That will help with their neuropathic pain and it will help with their anxiety and depression. And then there are other therapies for neuropathic pain, including patches and creams, oral and intranasal ketamine, which is mostly used in the hospice setting because it's really tough to use ketamine in the state of Louisiana, especially on the inpatient side. And oral or intranasal ketamine has not been FDA approved for pain. Also, don't forget about your complementary techniques. Acupuncture and deep tissue needling is very, very helpful for our patients living with cancer. Again, the same neural reprocessing. And then interventional techniques like nerve blocks, ablations, and neurolysis can help our patients with cancer. How many of you take care of patients with GI cancers? A lot of you. Celiac plexus blocks may not work on the first time, and yet you do them again. And then you do them a third time. And when that doesn't work, your IR clinicians can go in and they can actually burn the nerve off. That's what neurolysis is. So don't forget interventional techniques as a method to treat pain. Key management when your patients move from active cancer status to then survivorship and or stable disease status or remission is remembering that your patients have moved into the chronic pain realm. Opioids also, after about 10 days, the mind develops a physiologic dependency on them. So you have to wean people off of their opioids, otherwise they get really sick and they feel really crummy. So opioids are not the mainstay of treatment for chronic pain. You want to use your adjuvant agents, like your neuropathics, as well as muscle relaxants, like baclofen, Robaxin, Flexeril. You also want to use complementary methods like PT-OT, acupuncture needling, TENS units, and then also don't forget mental health techniques, CBT, DBT, when weaning patients off of their opioids, because there is a huge psychological component of that dependency. Please wean opioids as patients move towards cancer-free status. This is really important. Patients living with cancer, when they are out of the active phase of cancer, should not stay on 90 to 120 Percocets per month, right? We've got to start weaning them off. And the way that I do it is I let the patient choose. Would you like to wean the quantity, the number of pills you get this month, or would you like to wean the dose? So if they're on 15 milligrams of oxycodone and they're getting 90 of those from me per month, I'll ask them, would you like to wean by 10 tablets this month and keep the dose at 15 milligrams? Or would you like to wean it wean your 15 milligrams down to 10 milligrams. And I tell them that at some point we will be weaning both. Generally, and I won't say generally, there are a few patients that we can't wean them off completely. And as long as we get them down to about 20 to 30 tablets a month, that's usually pretty reasonable for PCPs to take over. Now, our next big category of symptom is nausea and vomiting. I'm just going to tell you that there are different causes of nausea and vomiting. So in your patients with cancer, it's important to figure out what is going on. Now, this cutesy little mnemonic called VOMIT can help you with that. So vestibular or vagal reasons, obstruction, especially for your cancers that have peritoneal carcinomatosis, mechanical motility or the medications, ingestion, ICP related or idiopathic. I should also put inflammatory because the inflammatory mediators of cancer can also cause nausea and vomiting, as well as the medications, the chemotherapy you're giving them, and then toxins like the inflammatory mediators. Yeah, that's where the inflammatory mediators went. So vomit, evaluating the causes of nausea. Now, this slide is not going to be readable from where you're at. You will get these slides, so these are my categories of medications that you can use for nausea and vomiting. And it includes serotonin antagonists, including Zofran, atypical antipsychotics, dopaminergics, anticholinergics. You will get this slide, so you have a full toolbox of medications to use for nausea and vomiting. Most people love to use Zofran. Most cancer doctors use Zofran, which is great. Really hits the chemo trigger zone in the brain. I would encourage you to use atypical antipsychotics as a next step, and I'm going to show you why. So before that, though, how to pick medications that work for nausea and vomiting. Think about your patient, avoid polypharmacy, and use a medicine that hits two birds with one stone. So some pearls, if your patient is really sick, tell them to schedule the medications. Don't miss a dose. Don't use it as needed. If you know you're going to get sick or your patient's going to get sick after chemo, schedule the medication. Inpatients should have scheduled medications, and give patients a backup in case their scheduled medicines don't work. I'm going to just focus on olanzapine, atypical antipsychotics. This is a New England Journal of Medicine article from 2016 that was published that showed that olanzapine in a randomized double-blind phase 3 trial actually did just as well as Zofran when treating nausea and vomiting, chemotherapy-induced nausea and vomiting. I love atypical antipsychotics because they pick up appetite and they help patients sleep at night. So keep that in mind. So this is, the data is primarily for nausea, vomiting, and appetite stimulation, especially Zyprexa, but you can use Seroquel. The side effects are sedation, which help us with some of our patients who need to sleep, and the QTC prolongation is not as much as when you're using Haldol as a typical antipsychotic. Now, therapeutic marijuana has very mixed data. In some patients it works, in other patients it doesn't do a damn thing, okay? So every patient of yours, especially the little bitty old ladies who want to go to the dispensary and get weed, tell them that probably not the best idea. It may work, but it may not work. There is a role for harm reduction for your patients with cancer who are going to dealers. Make sure that you are giving them a referral to the dispensary. I usually start patients on a 50-50 blend. I'm going to skip over this, and 50-50 blends are CBD plus THC. Okay, so a combination so that they have other symptoms that are helped, because if you give pure THC, sometimes that can worsen the nausea. Okay, I'm going to skip over this case example and just tell you the highlights because I know we're running short on time and I want to be respectful to my next presenters. Basically, if your patient has multiple symptoms like nausea and breathlessness, use a medication that works for both. You can use something like Vistaril that will help them with their breathing and will help with nausea, okay? Because Vistaril is an antihistamine, and those work for nausea management. So in summary and conclusion, palliative medicine is the care of seriously ill patients. Certainly in the world of cancer, palliative medicine and or supportive care, I like to call it palliative medicine because it is my subspecialty of medicine and I like its name, but palliative medicine and supportive care is appropriate for our patients living with cancer. Hospice is one branch of what we do, or end-of-life care, comfort care. And really, from a pain and symptom management standpoint, go low and slow with your medicines, use opioids appropriately, use the equianalgesia chart, when you manage nausea, use a medication that hits 2 to 3 birds with one stone, or 2 to 3 symptoms with one agent. And then end-of-life care has a lot of symptoms. We're always willing to help out when your patients are at the end of life. These are my references. Here are some resources, including vitaltalk.org, HAPC Virtual Didactics, which I run monthly lectures on hospice and palliative care topics with CME included that you can join in on. Palliative Care Fast Facts, which are one-page evidence-based topics on palliative care that you can access. And if you have any questions, please feel free to reach out. I've included both of my email addresses. Follow me on LinkedIn, and that's my wonderful team that helps me at UMC and EJ that helps me in this work. It's not all of them, I should say that. We have a few more members who are not in that picture, but these are incredible people, and we're always willing and able to help you with your patient care. Thank you all.
So I'm going to just pick up on a couple of things that Dr. Malhotra said, is sometimes words have connotations that are not completely accurate. And two words, morphine and hospice, tend to be thought of in a very negative way. But morphine is probably the most important single narcotic analgesic we have available to us in cancer patients. And hospice is a form of care that's for those who are living and trying to improve upon their quality of life. So earlier, I mentioned trying to make people whole. Cancer and any illness has a way of taking things away from us. And in our younger patients, cancer and cancer treatments can take fertility away. And this is a very precious thing that we don't want our patients to lose. Dr. Jay Huber is a reproductive endocrinologist and infertility specialist in the New Orleans area. He's the medical director of the Fertility Institute of New Orleans. He's also an assistant clinical professor in the Department of Obstetrics and Gynecology at LSU Medical School. Dr. Huber graduated from LSU School of Medicine in New Orleans. He completed his residency in OBGYN and a fellowship in reproductive endocrinology at the Warren Albert Medical School of Brown University. And he is at a national level. Dr. Hubert's on the developmental committee of the American Society of Reproductive Medicine and is a member of the research board for the Society of Reproductive Endocrinology and Infertility. Dr. Hubert.
All right, good morning. Can everyone hear me? Good? All right, so I really appreciate the opportunity to come speak to the CAGLA conference today. I'm always moved by joining other groups, meetings. You always learn a few things. The first thing I learned this morning was how versatile the word vomit is. In the world of gynecological surgery, that's victim of modern imaging technology, meaning that they found something that we weren't looking for to begin with, right? So thanks a bunch. Dr. Ellis, thank you. Thank you to CAGLA. You know, as an OBGYN and a fertility specialist, I consider myself what I call a roundtable doc. Not only do I see individuals, couples, families around a round table, I don't like to talk directly at patients, I like to speak with them. But also in terms of relationships in fertility preservation, it's important that I have a seat and all of our colleagues and many of you in this room, we sit around that round table to make sure that our patients afflicted with any type of gonadotoxic diseases can have the full breadth of a care team that can make our care not only expedient but effective. Going forward here. I do have a couple disclosures, none of which impact the validity of this talk. I get great pleasure from serving on some of our industry leaders and trying to further and advance some of the technologies that we do. I have a relationship with LabCorp, Hologic, and Ferring Pharmaceutical. So the goal of today is really to, number one, impart knowledge. And that knowledge really wants you guys to understand fertility preservation options for both biologically male as well as biologically female, their success rates, timing requirements, and then current guideline recommendations. We'll talk a little bit about clinical skills, some of the fertility discussions, the interventions, assessing patient goals. We want to match the appropriate preservation techniques with the various clinical scenarios. as well as coordinating care between the oncology team and the reproductive medicine team. So lastly, we'll talk about how to apply these skills, and we want to establish effective referral networks and document discussions appropriately, not only from the oncology, but also from the fertility medicine piece, and provide patient-centered counseling throughout the Cancer Care Consortium. Now, why do we feel it important as a field of reproductive medicine to catch up with our oncology hem-onc colleagues? It's because you guys have gotten so good at your job that we needed to get better in our job. So over the last decade to maybe 15 years, there's been a tremendous amount of research, tremendous amount of resources that have been provided into our field in getting better in serving patients to allow them in their realm of survivorship to continue to build their family. As you know, cancer survival rates now exceed 80 to 85% in children, adolescents, and young adults. Fertility is definitely a top concern in these reproductive age patients. I will do a phone call, Zoom, FaceTime, in person, however we can get a patient seen, reproductive age patient, we welcome the opportunity. One example, I did a phone call with a 15-year-old patient at Children's Hospital, a pretty sick kiddo, and she wanted to talk with a doctor about how to have babies in the future. And we went through about a 30-minute phone call, went through the whole process of, well, you know, we would involve injectable medications. We want to try and get as many eggs as we can now. That way, in your survivorship, we have the opportunity to build your family. And then I always tell patients, but look, if this is too much, if it's not something you're interested in doing, there are alternative strategies, such as things like donor egg, whether it's a known donor or what we call a directed donor, or a non-directed or an anonymous donor. And a 15-year-old, she says, oh, that's cool. I'll just do that. I said, great. Sounds like, look, if things change, let me know. And so the fact that we were able to educate and then empower this young lady to be able to make her own decisions, just a mere phone call, 30-minute phone call, I think it's going to change her reproductive goals for the rest of her life. And that goes to say that the earlier discussions, they definitely reduce distress and improve quality of life. In reproductive medicine literature in the realm of fertility preservation, that we quote about an 80% reduction in risk of regret later in life, regardless of whether we intervene with a fertility preservation technique or not. So a mere conversation, very important. So who are the candidates for these discussions? Obviously, prior to cancer therapy, chemotherapy, radiation to the pelvis, surgical interventions for cancer treatments such as oophorectomy, hysterectomy, or orchiectomy. We also see patients who are undergoing gonadotoxic treatments for other conditions, things like autoimmune diseases, myeloproliferative disorders. We also like to see patients, and unfortunately this is fairly rare because by the time these diagnoses are made, such as Turner syndrome or a Fragile X premutation carrier, Fragile X premutation carriers are at risk for a condition that we call premature ovarian insufficiency. We'll see in just a few slides, young women are born with all of their eggs, and so it's a finite pool for which we have to work with. And then lastly, transgender patients prior to gender-affirming treatment. So as far as timing and communication, really want to start these discussions at the time and the risk at the time of diagnosis before treatment initiation. Want to have the appropriate network in place to refer interested patients and even those that are uncertain. Those that say, there's a lot going on, not sure exactly what this involves. We welcome the opportunity for a 10-minute discussion, a brief overview of what the world of fertility preservation can provide. Want to document discussions in the medical record. The nature of medicine, we all are aware. I have sat on Louisiana State Medical Review Boards for failure to have conversations about fertility preservation later after cancer treatment. And then, as mentioned earlier, these patients are lifelong patients. We want to revisit annually during survivorship or even when treatment plans change. And I can't harp on it enough. Time is of the essence. We want to ideally complete any of these entities prior to chemotherapy or radiation. So this is just a summary of some of the more common offending agents, certainly not a complete list. But many of these chemotherapies you talk about on a daily basis. The one that gets me the fastest is cyclophosphamide. Anytime there's, now mind you, I'm an OBGYN, I focus on the biologically female aspect of fertility preservation, and I do have colleagues that do more of the male piece. But cyclophosphamide is certainly one that we would label as high risk, as you see in that right side, in that right column. And then as we go down the list, there are some more medium risk and low risk. My opinion, any risk is too high. Now, this is not a complete list. With the advent of more advanced agents such as biologics, and in the breast cancer world with ER/PR positive cancers and utilizing hormonal treatment, the good news there is that the early evidence that we have is that those are even lower risk than the chemotherapeutic agents that you see here. ASCO did a really nice job in collaboration with the American Society of Reproductive Medicine, the American College of OBGYN, with coming up with some really nice guidelines in terms of, we all like guidelines in one place. Where can we find them? Where can we review them? And are they evidence-based, right? So ASCO did a nice job publishing these guidelines and updated guidelines in 2025. So in all patients impacted by cancer, we want to discuss infertility risk as early as possible. We want to refer interested patients over to reproductive specialists, and then documentation is key. In biologically male, we want to make sure that we offer sperm banking, which is a well-established technique. As well as in the event sperm banking is not feasible, we want to discuss offering a TESE, or testicular extraction of sperm, if unable to produce the specimen. Very well-established technique. Hormonal suppression with medications such as GnRH analogs to stop the hypothalamic anterior pituitary testicular axis do not show as much benefit in the biologically male population. In female, offer embryo or oocyte cryopreservation, very well established. Offer ovarian tissue cryopreservation, very newly established, right? And not only is it very newly established, it is a far more advanced technique that the access to those types of treatments are limited at current state. So we may offer GnRH agonists, so some medication like Lupron as an adjunct, specifically in the breast cancer population, but my opinion is in every patient undergoing gonadotoxic therapy, try and shut down the HPO, ovarian axis, so that the eggs kind of go into a sleep mode. And then consider ovarian transposition for pelvic radiation. So moving into more specific male preservation techniques, first line is going to be sperm cryopreservation, or known as sperm banking, right? First line for pubertal or post-pubertal males can be done very quickly. Collection every 24 to 48 hours prior to starting chemotherapy. We make vials of sperm, can be utilized for either intrauterine insemination later in life if the quantity is high enough, or utilized in the in vitro fertilization technique. Even limited samples are very successful. The limited samples, we are able to fertilize eggs with a technique called ICSI, or intracytoplasmic sperm injection, where under a microscope we can direct a single sperm into the egg to help with fertilization. So when asked how many sperm do I need, I say in certain scenarios, as many as we can get. Just get me something, right? From testicular tissue, from ejaculate, whatever it is, just get us some sperm. And this should be done before treatment initiation. If unable to sperm bank via masturbation or collection techniques, then testicular sperm extraction is a very viable method. This is something where a reproductive urologist would go in surgically and take sperm either from the epididymis or directly from the seminiferous tubules in the testicle. And as well, this should be offered before cancer treatment. Just to reiterate, the shutdown of the HPT, or the testicular axis, is not as effective with GnRH analogs. Prepubertal males, testicular tissue cryopreservation definitely remains investigational. Should be done under an IRB or in a clinical investigation or a trial. Some of the post-treatment considerations after chemotherapy, there is higher risk of genetic damage in sperm collected after treatment, so our goal is to utilize sperm that is collected prior. And then sperm quality may be compromised even before treatment. So we know that like much in healthcare, that chronic diseases can impact other biological systems such as sperm. Now, post-chemotherapy, we typically recommend that if we're going to use an ejaculated specimen instead, and if we don't have any sperm that was cryopreserved, we typically give 1 year, right? A minimum of 1 year to utilize that sperm for reproductive means. The nadir, or the decline in sperm after chemotherapy, ranges from about 2 to 6 years, but many times reproductive age men do regain sperm in the ejaculate, but would not recommend utilizing that sperm for a minimum of 1 year after the last dose of chemotherapy. All right, show of hands, anybody been in the Superdome before? Terrific. It's a local conference, so I would hope so. I use the Superdome as an analogy. I like analogies, especially when you talk about complex issues like oocyte cryopreservation, how the ovaries work, how the menstrual cycle works. So think about the ovaries like the Superdome. When young women are born, there's about 1 million eggs in the dome. By the time they go through puberty, half of those eggs go home. But what the other 500,000 do is they start to go to their seats. You've got some sitting up in the terrace in the sections, you've got some sitting in the club, and then you've got some in the plaza. And every menstrual cycle, what's happening is we have a conductor, she's out in Champion Square, she walks into the Superdome and she takes out one section of eggs. So for instance, in one menstrual cycle, she goes in and she says, okay, section 343, get up. Just the eggs in section 343, that's where my wife's tickets are, they're my wife's, they're not mine. It's 343, get up. Just the eggs in 343, get up, and they roll outside to the ramp. Now, depending on age and ovarian reserve, there may be 5, 10, 15, 30 eggs from section 343 that make it outside to the ramp. And in a normal menstrual cycle, that conductor then starts a competition out on the ramp, takes about 14 days for one of those eggs to win the competition. That's the egg that gets to ovulate. The rest of the eggs from 343 go home. They don't get to go back to their seats, right? So every menstrual cycle is just a different section of eggs coming out from the dome to the ramp. Competition starts, one ovulates, the rest go home. So in the world of fertility medicine, and certainly in fertility preservation, the way I describe it to patients is every treatment cycle that we do, we're not messing with what's going on in the dome. We're only manipulating the eggs that are out on the ramp. So with pills, we just rig that competition a little bit. 1 to 2, sometimes 3 or 4, ovulate, and that's where we get more eggs to meet up with sperm. In something like an IVF cycle, same principle. We're not messing with what's going on in the dome. So what we're doing is we're using 10 to 12 days worth of injectable medications, gonadotropins, to rig the hell out of that competition. If there's 5, 10, 20, 30 out on the ramp, we want them all to win, right? So we want every single egg out on that ramp to win, so that when we go to egg retrieval, we go in with a needle, ultrasound-guided needle, and we pick up every egg off of the ramp, right? So then once we go through that process, we talk about, well, what's gonna happen to the eggs in the Superdome when I undergo my treatment? That's the part where, yeah, the eggs in the dome may take a little bit of a hit based on the dosing or the type of medication or type of chemo, the type of the dosing, how long the dosing's happening, plus or minus radiation, et cetera. So that's a really nice analogy that I like to use for patients. And then I'd say, look, if we're going to use a GnRH agonist, something like Lupron, what that's going to do is we're going to try and put all the eggs in the dome to sleep. That way, when you're done with your chemo, there's a chance that some of those eggs in the sections, hopefully up at the top, in the middle, they wake up a little bit and our ovarian function is started to happen again. So going into some of the treatments that we do, oocyte cryopreservation, certainly over the last decade, has taken the forefront of fertility preservation in terms of being able to go quickly and protecting reproductive autonomy of young women after chemotherapy. It's an established method, no partner required, no sperm, nothing needed. It's very well suited for individuals with religious or ethical objections to embryo freezing. Live birth rate, pretty reputable, 32% in one study. And then ultimately the cumulative live birth rate, about 35 to 37% per patient. Second option would be embryo cryopreservation. So very established, highly effective method. Over a decade ago, when we were talking about fertility preservation, embryo cryopreservation was the one to do. Reason being is you can freeze, you can cryopreserve anything, right? It's the ability of that entity to survive the thaw. So oocytes previously were not very stable, and embryos were far more stable in the ability to survive the thaw when we went to utilize that tissue. Nowadays, in our lab, eggs are about a 92% thaw rate, embryos more in the 98 to 99%. So still a small increase, but the egg, the ability, that's where we've put a lot of our efforts, is to catch up with oocytes. Oocytes allow individuals to still, female patients to have reproductive autonomy over those eggs. Once you make an embryo with a partner, that becomes community property, essentially. You need to be able to, you have to have both parties agree to utilize that embryo. Eggs, you're the boss. So glad we've been able to catch up with oocytes. So both require ovarian stimulation, and we'll go through that in just a second. Specialized center with expertise. So we do an ovarian stimulation cycle. So remember, that conductor is going to go in, regardless of where we are in the menstrual cycle. That conductor brought eggs out to the ramp. We're going to use 10 to 12 days worth of injectable meds. We're watching on with ultrasound and blood work over that process, on average 4 to 5 times during that 2-week period. We then undergo an oocyte retrieval to retrieve the eggs under anesthesia. It takes about 15 or 20 minutes. We then preserve the oocytes, or we fertilize with sperm. And really, the downside to this approach is that it's only an option for either peripubertal or postpubertal patients. So specifically talking about breast cancer, refer all premenopausal patients to reproductive medicine for if desiring future pregnancy. We can utilize a medication called letrozole. It's an aromatase inhibitor, especially in these estrogen receptor positive breast cancers. In a standard oocyte cryopreservation cycle, we can see estrogen levels up into the 2,000, 3,000, 5,000 picograms per ml. So our role and our goal utilizing letrozole, which again is an aromatase inhibitor, 5 milligrams per day, is that the aromatase inhibitor is incredibly effective at keeping estrogen levels even lower than we would see in a natural menstrual cycle. So the oocytes continue to develop under the control of that injectable gonadotropin, but in addition, we can use letrozole to make sure that risk is mitigated in estrogen receptor positive cancers. So pregnancy after treatment, especially in breast cancer, generally considered safe. No increased risk in short-term data. Traditionally, we recommend at least 2 years disease-free before attempting conception. And as it seems in the literature, present day, temporary interruption of endocrine therapy for pregnancy has no bearing and is definitely an option. So when do we start this? Well, in a perfect world, or what we thought was a perfect world, dogma in the world of in vitro fertilization and controlled ovarian stimulation with injectable medications, was we like to start that cycle in what we call the follicular phase. Cycle day 2 to 3, with cycle day 1 being first day of full flow. Cycle day 2 to 3, we start our injectable meds when all those eggs have just gotten out to the ramp. We want to make sure that we can rig the competition and get as many eggs as we can. Well, when we see a patient in the office that is looking to start chemo in 1 week, 2 weeks, 3 weeks, we don't have that luxury. So we do what's called a random start. So the random start is, what day are you today? Terrific, we'll start tomorrow, right? So we go after, because remember in that analogy, even if that winner has already ovulated, there are still several eggs out on the ramp that we can go and rescue prior to their atresia and that conductor going in and getting another cohort of eggs. So what we have found, random versus follicular starts, is that there's no significant difference in any of the important measurable entities. Total oocytes retrieved, fairly equal. Mature oocytes, right? So in the process of controlled ovarian stimulation, we want follicular development for a number of days because we need those eggs to become mature haploid cells. They kick out a polar body and they become haploid where they can be fertilized. So mature oocytes retrieved are equal. Fertilization rates are also equal. The benefit of a random start is time. I see a patient on a Thursday, I start them on a Friday or Saturday. 2 weeks later, we're wrapping them up in a pretty little bow and handing them right back to you guys. So with the eggs in liquid nitrogen. So we can complete things, and I give patients about a 2 to 3 week max just to get everything lined up. So ovarian tissue cryopreservation, newest player on the block. It's now established, but very new. No ovarian stimulation required. Can be done immediately if emergent therapy is required. It's the only option for prepubertal patients. Certainly, we've found some pretty interesting evidence that it can restore both fertility and ovarian hormone function when reimplanted. Some of the success rates, live birth rates after transplantation, pregnancy rates are quite good. Ovarian function. So remember, the ovary is not there just for reproduction. It's there for important hormones, estrogen, testosterone, etc. So resumption of menses is very protective for heart, bones, mind, those types of things. So the function of the transplanted tissue can seem to stay steady for 4 to 7 years after transplant. So some of the considerations, it does require laparoscopy or surgical procedure prior to the start of chemo. Later transplant is needed for the tissue to become effective. And there is a risk of reintroduction of malignant cells, especially higher risk in bloodborne cancers such as leukemia. How do we do it? Well, there's 2 different ways to do it. There's the ovarian cortical tissue cryo, where you can cryopreserve 1 to 2 millimeter slivers of the ovarian cortex. And then when you go to reimplant, 2 different types of implantation. There's orthotopic, where you can put the ovarian tissue back into the pelvic site or in the ovary or the ovarian fossa, the ovarian bed. Or heterotopic, where the tissue is placed in a site other than the pelvis, such as the forearm or the abdomen. Whole ovary cryopreservation, not necessarily effective. This is an area of focus where the issue with whole ovary is that the cryoprotectants can't get to the tissue. That's where the slivers become very important, where the cryoprotectants can get to the tissue so that when they are exposed to very cold conditions, such as liquid nitrogen for storage, the ability to be functional when thawed still remains. This is a picture of an ovarian segment, a piece of ovarian tissue that is grafted onto alloderm. This is, so Kokturk Oktay, a doc up at Columbia, is a colleague of mine. He has been at the forefront of ovarian tissue cryopreservation. And he's published a nice series of articles about the utilization of tissue. The picture here is one where he's prepared a segment of ovarian tissue for reimplantation. It's embedded on a graft of alloderm, and then can be placed right back into the ovarian bed with robotic surgery or laparoscopic surgery. So other things in addition to oocyte, embryo, and then ovarian tissue cryopreservation, sometimes ovarian transposition or oophoropexy, that's a mouthful, for patients requiring pelvic radiation and the success is not guaranteed due to the radiation spread, should be performed closer to the time of radiation. We spoke a little bit about GnRH agonists, or leuprolide acetate in the world of gynecology is one that we use a lot. I know that in pediatrics and in oncology, there are several other analogs of GRH that are available. The whole goal with this is just to shut down the HPO axis. What we're looking to do is put the eggs in the dome to sleep. until we're done with chemo. So that can be a monthly injection while chemotherapy is happening. It's not to replace established methods, but certainly to be utilized as an adjuvant. May be offered for breast cancer patients, my opinion, all cancer patients. May benefit biologically female patients. May benefit those who need to undergo urgent chemo and we don't have time to get eggs. And there is a known protective effect on ovarian function post-chemo. One of the more investigational methods of cryopreservation is in vitro maturation. It is emerging. This is where we go in without any ovarian stimulation, go get immature eggs, and then in the lab we would need to figure out how to make them mature so that they can fertilize. Very limited data. So what's the impact of age on outcomes? So oocyte quality declines with age, we know that. For oocyte cryopreservations in less than 35-year-old individuals, we've got 15.4% live birth. As the number of eggs go up, we increase the number of the live birth percentage. Ovarian tissue cryopreservation, while it is a new established technique, it has been shown to be effective. The message here is earlier the better. This is a summary table that you can read at your leisure. It just kind of goes through the methods of embryo, oocyte, ovarian tissue cryopreservation, the live birth rates, and then some of the key considerations. How many people come back and use this tissue? Not many, but still it's available. Most recent published data that we have was a large trial or a large study that looked at a 5 to 7 year follow-up. Only about 5%, 5 to 8% of patients came to and used those oocytes. 78.5% were able to get a usable embryo. Cumulative live birth rates close to 30%. And then not surprisingly, the older patients were more apt to come back sooner to utilize those eggs. As far as ovarian tissue cryopreservation, again, this is mainly done in the pediatric population, so not surprising that the number of the recipients is still fairly low. Other special populations, the prepubertal, we mentioned that ovarian tissue cryopreservation is really the only option. There's no live births yet reported from prepubertal tissue, but I think as the years go by, we will start to see it. Males, we talked about testicular tissue cryopreservation. So not just pretreatment. Can we offer this to patients who have undergone treatment already? While the outcomes may be lower, they're certainly not zero. Patients who did not preserve gametes initially are welcome to have conversations about what a cycle would look like. Those needing additional preservation techniques for family building. Survivors at risk for age-related fertility decline. Anyone that has had gonadotoxic therapy have a risk of having premature ovarian insufficiency. For biologically female, embryo oocytes may still be offered, as well as males, limited post-treatment options because the sperm may be compromised, but we're always willing to give it a shot, certainly after that 1 year. Some of the barriers, system level, patient level, right? Reproductive medicine is not immune to these, like you guys see in several of your patients. Lack of insurance coverage, financial constraints, and certainly disparities exist between age, race, cancer types, and socioeconomic status. Now, what is the solution, or one of the solutions? 21 US states plus DC now require insurance coverage, private insurance coverage for fertility preservation. And I am proud to announce that Louisiana did follow suit in 2023. I think some people in this room had a large part to do with that as well. Myself, one of my partners, Nicole Ulrich, at Pheno, have to give credit to the docs at Fertility Answers in Lafayette and Baton Rouge, Neil Chappell, John Storment, Representative Paula Davis, and then Katie Bliss, one of our reproductive attorneys here, patient of fertility medicine as well as patient advocate. Tremendous effort put towards this. And yes, it's incomplete, but it's something. It's a start. It started the conversation. It started the ability of us to get in and to move legislation in the right way. Without insurance, out-of-pocket costs can range $6,000 to $10,000. Medications, $2,000 to $6,000. Sperm cryo, cheaper. I want to say some patients may be able to afford the consult alone. I can only speak for the Fertility Institute. private insurance, no insurance, state-based insurance, we will never decline a fertility preservation consult based on inability to pay. Patients they deserve at least a conversation. So if there is no coverage and inability to pay, we will gladly do those conversations pro bono. A phone call for me, for them, it's priceless, right? So we welcome the opportunity for any conversations about fertility preservation. Matter of fact, my 15-year-old, my very apt 15-year-old was a state Medicaid patient. Mom was concerned about cost, and if I would not have done that phone call, I don't think I would have had one of the most impactful phone calls I've had in the realm of fertility preservation. We do have some great partnerships. Some of our pharmaceutical companies, Ferring is one of them. EMD Serono is another. There are various programs that we can get very low cost, if not free meds. Screen, clinical flow, definitely need to screen patients who assess gonodotoxicity. Step 2 is refer. Step 3 is coordinate. And then step 4 is to follow up. And the big thing about follow-up is we need to reassess on an annual basis during survivorship. The essential team, it's definitely a round table, right? I mentioned that round table earlier. Multidisciplinary, oncology, REI, mental health, financial, nursing staff, patient advocates, former patients who have gone through this, huge patient advocates. Coordination's needed, timely fertility consults, assess fertility preservation treatments, financial navigation, psychosocial support, future directions. We mentioned IVM, in vitro follicle maturation. We need to improve protocols. I'd love to do this quicker, but with better results. Online risk assessments, research needs. We need long-term follow-ups, cost-effectiveness trials, better patient satisfaction and morbidity rate, better coverage, better payment plans. So take-home messages, would love to reiterate, diagnose early, discuss early, refer liberally. Multiple options exist. Welcome patients to have those conversations. We'll talk about established methods, whether it's embryo, oocyte, sperm cryo, ovarian tissue cryo. Some of the successes, they range 25 to 40%. Time matters, but options exist, pre and post. Post-treatment preservation, worth a conversation. Document everything, discussions, referrals, decisions in the medical record. The bottom line is fertility preservation is an essential component, and we welcome the opportunity to play a role in it. So I appreciate your time. Thank you for everything that you do. Thank you for the opportunity to be here.
So the Superdome will never be the same to me, but that was...
Second-year medical students, that's the ones that...
So our next two speakers are treasured colleagues and members of our Touro Oncology team. Terry Bateman is a dedicated oncology nurse with nearly 30 years of experience supporting patients and families throughout their cancer journeys. A graduate of Charity Delgado Nursing School, Terry has spent the last 13 years serving the Cancer Center at Touro LCMC, where she plays an integral role in patient care, program development, and survivorship support. For the last 3 years, Terry has served as a survivorship coordinator, leading efforts to expand, strengthen the hospital's survivorship program. Terry's fun fact is she brings joy, rhythm, and spirit to her work and community as a proud member of the LCMC marching crew, the Heartbeats. Rachel DeMario McNamara is a board-certified oncology physical therapist and supervisor of Touro Infirmary's Cancer Rehab Clinic. Originally from Baton Rouge, she obtained her bachelor's degree in biological sciences from LSU. Her career in oncology began while attending graduate school at LSU in Shreveport, where she was selected among her class to complete a clinical rotation at MD Anderson. Rachel has worked exclusively in the oncology setting for the past 6 years and recently became one of 2 board-certified clinical oncology specialists in the state in 2025. She currently leads a team of dedicated physical, occupational, and speech therapists at Tulane's Cancer Rehab. In her spare time, Rachel enjoys spending time with her husband Ryan and her 2 cats. She may even be spotted dancing in the streets with her ABBA-themed dance crew, Voulez Crew. So you may notice that from these bios that dancing is very important to people who work at Turo. And if you're interested in coming to work with us, we can set up an audition.
Good morning. Please bear with my voice. I've been attacked by the pollen today, so. All right, so today we're going to talk a little bit about survivorship, how we integrate supportive services derived from the distress thermometer, and how this can help survivors continue to do well throughout their life. All right, cancer survivorship has become an essential component of modern oncology due to increasing survival rates and shifts in treatment paradigms that allow more individuals to live longer after diagnosis. Survivors frequently contend with a multitude of long-term and late effects spanning physical, emotional, social, and financial domains. If left untreated, distress can worsen clinical outcomes, hinder adherence to follow-up care, and significantly diminish quality of life. Research demonstrates that cancer-related distress is highly prevalent, yet under-recognized, with many survivors reporting unmet psychosocial and supportive care needs. This highlights the necessity for structured, proactive survivorship care models that incorporate distress monitoring, timely referrals, and coordinated multidisciplinary support. Survivorship care also emphasizes continuity across cancer course, recognizing that patients' needs evolve from active treatment into long-term follow-up. This involves addressing fatigue, cognitive challenges, emotional distress, nutritional concerns, role changes, financial toxicity, and social isolation. Healthcare systems that implement comprehensive care frameworks, such as integrating navigation, counseling, rehabilitation, lifestyle interventions, and preventative health programs, promote resilience and empower survivors in their recovery. The survivorship journey further extends into enhancing well-being, reinforcing post-treatment identity, and supporting reintegration into daily life, work, and relationships. By acknowledging survivorship as a distinct phase requiring dedicated resources and infrastructure, oncology teams can deliver personalized, holistic care that reflects best practices and current evidence. Collectively, these efforts contribute to improved clinical outcomes, reduce psychosocial burdens, and the overarching goal of helping individuals not merely survive cancer, but truly live well beyond it. All right, what is distress? Distress is recognized as a multifactorial experience encompassing emotional, physical, social, spiritual, and practical concerns that can significantly influence a patient's cancer experience. Despite its prevalence, distress is frequently underscreened in oncology settings, partly due because clinicians' limited familiarity with validated tools and challenges integrating screening processes into clinical workflows. Effective distress management begins with the use of a validated patient-friendly screening instrument capable of capturing the broader perspective of distress rather than isolated symptoms such as depression or anxiety. These tools should be ideally brief, inexpensive, and easily incorporated into the EMR to facilitate routine use. The one we're going to concentrate today on is the NCCN Distress Thermometer. We'll call it DT for short. It has emerged as one of the most widely adopted tools due to its simplicity, visual analog format, and accompanying problem checklist. When a cancer program is implementing the use of the DT in survivorship, it is important to have the workflow aligned with organizational capabilities. Barriers such as inconsistent screening practices, lack of follow-through on referrals, or insufficient linkage to supportive services can reduce screening effectiveness. Nonetheless, consistent use of validated tools remains central to evidence-based survivorship care, improving early detection of distress, guiding individual intervention plans, and ensuring that supportive care resources are deployed appropriately. Ultimately, validated screening tools form the backbone of proactive, holistic survivorship programs that strive to improve patient well-being. Okay, here's the NCCN distress thermometer. We at our facility like to administer this at the initial visit. We'll also administer it as needed if in infusion they feel that the patient is having distress. We'll find out what's causing it. We'll also administer this in radiation, and then I'll administer it in my meeting with them for survivorship. And on the left-hand side are the concerns that a survivor may have, and from that is how we make our referrals. All right, so how is this NCCN distress thermometer, how is it structured? So it's a streamlined evidence-based tool designed to assess cancer-related distress through a simple 0 through 10 scale accompanied by a comprehensive problem checklist. It is recommended for routine use by leading organizations including NCCN, ASCO, and the American College of Surgeons Commission on Cancer. The DT captures distress across multiple domains: emotional, physical, family, practical, spiritual, allowing clinicians to identify underlying issues driving patients' distress scores. In many real-world applications, a score of 4 or higher serves as a threshold prompting clinical interventions such as referral to counseling, nutrition support, palliative care, rehabilitation, or financial guidance. The DT's usability across different cancer types and care stages from diagnosis through survivorship has supported its widespread adoption. Tailoring its use to the specific resources and staffing of each institution is therefore essential for optimizing its impact. When effectively integrated into clinical workflows, the NCCN distress thermometer enables timely psychosocial interventions, improves patient coping, enhances emotional well-being, and ensures survivors receive comprehensive patient-centered care that supports quality of life. Referral pathways linked to the NCCN distress thermometer are integral to ensuring that distress screening results translate into actionable patient-centered care. Many institutions commonly use tiered models in which distress scores, particularly those at or above 4, activate specific intervention pathways. These pathways may include referrals to behavioral health, providers for emotional concerns, social workers or financial navigators for practical challenges, dietitians for treatment-related nutritional issues, navigation service for care coordination needs, or rehabilitation for physical limitations. Real-world evidence highlights that these pathways vary widely, reflecting differences in clinical settings, available services, and staffing structures. Some organizations employ nursing staff or medical assistants to administer screenings and initiate referrals, while others integrate these tasks into electronic health systems that automatically flag concerning scores. And despite this variability, the fundamental goal remains consistent. You have to connect survivors promptly to tailored resources that can alleviate distress and enhance resilience. At our facility, our navigator will receive the distress thermometers at the initial visit, and she'll triage those. Anything above 4, she will call the patient and see if they would like that referral. And the other one, she will still call to let them know about the supportive services that we offer throughout their cancer journey. Integrated survivorship support models aim to address the wide spectrum of challenges cancer survivors face by coordinating physical, emotional, social, and practical care within a unified framework. Evidence shows that comprehensive approaches informed by distress screening enhance access to timely supportive services, improve symptom management, and reduce psychosocial burdens. These models often incorporate interdisciplinary teams, counselors, dietitians, nurse navigators, palliative care specialists, financial navigators, rehabilitation therapists, and wellness providers to ensure alignment of care across domains. Now, flexibility is critical. Organizations must tailor their workflows to available resources, staffing patterns, and patient populations. Survivorship programs that adopt NCCN distress thermometer protocols to their specific context are more likely to provide effective, responsive care. Benefits include improved treatment adherence, greater patient satisfaction, enhanced emotional resilience, and strengthened caregiver support systems. By prioritizing communication, regular assessment of needs, and easy connection to specialized services, integrated survivorship models help survivors transition from active treatment into long-term wellness. They promote independence, empower self-management, and facilitate reintegration into the work, family, and community life. Ultimately, these models reflect best practices in survivorship care, ensuring individuals not only survive cancer, but learn to live well. If our facility does not have a supportive service that somebody is looking to, then we can refer out into community. And all this is documented into the chart. All right, next I'll let Rachel read about some of our supportive services and how they enhance survivorship.
All right, thank you, Terry. So, like Terry and Dr. Ellis were saying, I'm a physical therapist by background. I'm actually taking the place today of Toro's nurse navigator, but we'll be all right. I get to just talk about my colleagues. All right, so first up, we have clinical and emotional support services. So these are foundational roles in establishing and fostering the well-being of patients throughout the entire cancer care continuum. For instance, our oncology counselors provide specialized psychological care to address issues such as anxiety, depression, trauma, coping difficulties that we so often see our patients go through during and after treatment. Psychological services align with the NCCN guidelines for not only timely intervention, but also to just help patients mitigate these feelings and to promote emotional resilience. We heard earlier a wonderful talk about our palliative care colleagues and that they provide a wealth of services, not only for just end of life, but as well as to mitigate and manage symptoms, discuss goals of care, and helping to navigate the truly difficult and complex medical decisions that our patients so often face. We also are fortunate to have our oncology dietitians who provide targeted and individualized nutritional guidance and can also help with symptoms that we often see, such as weight fluctuations, nausea, vomiting, GI distress, and fatigue, while trying to optimize long-term health outcomes. So as we can begin to see, just from this one slide, these services help to create a clinically robust and supportive environment for these patients' individualized needs and to address them holistically. There we go. Like I said, I'm taking the place this morning for our wonderful nurse navigator, but nurse navigation and survivorship coordination really work hand in hand in my experience and from what I observed between Terry and Danielle. So there are two services that are essential for reducing the uncertainty, enhancing the communication, and ensuring smooth transitions throughout the different phases of care. Nurse navigators serve as consistent points of contact for patients, helping patients understand the treatment plans, scheduling and attending appointments, and accessing the appropriate supportive services when needed. Their role really helps to reduce the uncertainty that these patients face and often provides reassurance during really vulnerable times in their life. In addition, the survivorship care coordinator often extends the support by developing individualized survivorship care plans that address maybe late and long-term issues that patients may face. They can help coordinate and keep track of follow-up schedules, provide lifestyle recommendations, and set some wellness goals for patients to kind of think about their needs as they emerge over their lifetime, and to arrange referrals as needed, both internal and external, as Terry was mentioning. Together, these navigational roles help to overcome lots of barriers of care and really empower patients to promote continuity and to keep up with their treatment to foster wellness. All right. We also have practical and financial challenges as being one of the biggest causes of distress and what patients will so often note on their distress thermometers that come through. So, and these are really significant because while they might not be medical issues per se, they can really hinder access to care and things that we want patients to accomplish. The financial navigators play a vital role in mitigating these burdens. They can help patients understand their insurance coverages, explore financial assistance programs, enroll in grants, figure out appeal denials, and manage out-of-pocket expenses. By addressing this, though, again, frequently noted on the NCCN distress thermometer, they help to support treatment adherence and reduce the risk of financial toxicity, which can last a long time even after the treatment and therapy ends. Practical support services also may include things like coordinating transportation, employment guidance, and connecting patients to other community resources to help supplement what they might need throughout their treatment journey. And again, the financial and the practical services help to ensure that these essential non-medical needs are recognized and are addressed proactively. Okay, this is more my speed. We're also fortunate to have a well-rounded rehabilitation clinic that includes physical, occupational, and speech therapy. So rehabilitation and wellness are critical elements of a comprehensive care model because they can not only address the physical needs, but also emotional and functional challenges that often persist after treatment and after therapy. Rehabilitation specialists address and assess issues such as fatigue, neuropathy, lymphedema, pain, and reduced mobility, and helping these patients regain their strength, their independence, and just their daily functioning. These often work with complementary wellness programs, such as our yoga class, our support groups, and educational wellness talks. These I feel like they're so important because they provide opportunities for connection and enhancing emotional well-being, and to find like-minded people to talk about their stress in a safe environment. We also encourage and are sometimes successful in convincing patients to take up with gym memberships or structured exercise programs even long after they're discharged or graduate from therapy, just to help to maintain their health journey and encourage sustainable lifestyle habits for cardiovascular fitness, bone health, mental clarity, all the things that we encourage in the different disciplines. But these interventions not only help to alleviate the physical symptoms, but and really empower and promote self-efficacy for these patients, which is key and so important for successful survivorship. So by offering these services, we can help to rebuild confidence and establish a renewed sense of normalcy, helping to transition from just surviving cancer to really thriving and living well beyond it. Okay, and then lastly, we have some prevention, screening, and behavior change initiatives, which are also important for helping to reduce the recurrence risk and promoting overall health. So first up, our smoking cessation programs help to help survivors eliminate tobacco use, which is a major contributor to poor outcomes and secondary cancers. Dedicated smoking cessation coordinators offer personalized counseling, pharmacotherapy guidance, and motivational strategies to help support the long-term abstinence. closely related, our lung cancer screening nurses ensure that high-risk individuals undergo appropriate surveillance, enabling early detection and timely intervention. These prevention-oriented services align with evidence showing that effective survivorship addresses consequences of not only the prior treatment, but modifiable risk factors that could influence future health. The behavior change support, integration into distress-informed referral pathways help patients to adopt healthier lifestyles, improve treatment tolerance, and enhance emotional well-being. So in conclusion, connecting all these services to the distress thermometer that Terry was mentioning help oncology programs strengthen their ability to deliver comprehensive and proactive survivorship care really tailored and individualized to our patients' needs. So with that being said, I'm gonna hand it off to Terry to take us home.
Thanks, Rachel. All right, let's finish up here. How does the distress thermometer drive referral integration, holistic support, quality of life enhancement, institutional strengths, and program impact? All right, so when you integrate the NCCN distress thermometer into survivorship care frameworks, it enables oncology teams to make timely, personalized referrals that directly address identified patient needs. A DT score at or above a commonly used threshold that was 4, it serves as a catalyst for intervention, prompting clinicians to examine the problem checklist and connect survivors with the appropriate services. Real-world workflows vary, but successful programs share key features. They clearly define referral criteria, interdisciplinary collaboration, accessible support services, and mechanisms for follow-up and reassessment. Flexible implementation is essential as studies emphasize that institutions must tailor pathways based on available staffing, clinical settings, and resource capacity. Remember, you can refer outside of your supportive services if your facility doesn't offer it. When integrated effectively, distress-driven referral systems ensure that distress identified during screening leads to meaningful patient-centered action. This enhances care continuity, supports emotional and physical recovery, and promotes a comprehensive survivorship model that adapts dynamically to evolving patient needs over time. A holistic survivorship framework seeks to improve quality of life by addressing the interconnected dimensions of health that influence a survivor's overall well-being. This includes managing ongoing physical symptoms, supporting emotional stability, enhancing social connectedness, and strengthening functional capacity, and reducing financial or practical burdens. Integrating support services, like the ones we've mentioned, create a multidimensional system capable of meeting diverse survivors' needs. Distress screening acts as the entry point that guides personalized intervention strategies, ensuring survivors receive the right support at the right time. Programs that emphasize holistic care demonstrate improved emotional resilience, better symptom control, and increased patient satisfaction. By fostering independence, empowering healthy behaviors, and reinforcing survivor identity, holistic models help individuals move beyond the challenges of cancer treatment toward meaningful recovery and sustained wellness. Ultimately, this approach supports the overarching goal of survivorship care, enabling individuals to transition confidently from surviving cancer to truly living well. A robust survivorship program leverages institutional strengths by offering a comprehensive suite of supportive services that align with the best practice guidelines and evidence-based recommendations. By integrating supportive services, we create survivorship institutions create an environment that supports patients across all stages of their journey. The impact of this model is reflected in improved patient engagement, enhanced care continuity, and reduction in unmet supportive care needs. Evidence highlights the value of flexible workflows that allow programs to customize distress screening and referrals according to available resources and patient population. Institutional commitment to interdisciplinary collaboration and preventative health further enhances long-term outcomes, contributing to improved resilience, greater satisfaction, and a higher quality of life among survivors. And ultimately, these programmatic strengths position institutions as leaders in survivorship care, demonstrating that comprehensive, integrative support services can help individuals thrive beyond cancer. Okay, and in the matter of time, let me just shorten this. Your key takeaways for oncology professionals is make sure you screen frequently for distress using a validated tool. Like I said, we use the NCCN distress thermometer. Anything above 4, you want to make the appropriate referral quickly. And you also want to make sure you're assessing patients throughout their treatment, at the beginning, during, anytime you see stress, and during survivorship. Okay, and then oncology teams are encouraged to integrate survivorship-centered thinking into daily practice by consistently employing the distress tool and tailoring the patient's needs and care plans based upon their distress. Okay, that's it.
So I want to wrap this section up to just talk a little bit more about teamwork. The amount of time a cancer patient gets with their oncologist is relatively short across the spectrum of their treatment. And when we're in the room with them, a lot of times it's very problem focused. Sometimes they're uncomfortable talking to us about certain things. And without a team, a lot of things will get missed. And I thought of an anecdote of something that happened yesterday in the clinic where I had a visit with a patient and everything seemed fine. She was like, I'm good. We were setting up an adjuvant therapy plan. And she went home and really kind of started panicking about the medicines. She saw a commercial about one of the drugs, and it mentioned the toxicity, and she became very distressed. And we got her back in, and it really took a team effort. Something that just triggered her that she saw on a commercial about the drug Kisqali, which is a fairly safe drug, but you just never know when something like that's going to happen. And the only way we were able to help her was everybody worked together as a team, and I have the good fortune of playing for one of the best teams in the city. So thank you all very much. So if y'all have any questions for any of our presenters, feel free to. Anyone? Okay.
So the question is how to refer to palliative medicine. Yes, you can put in a referral in Epic for those who are from outside of the system. We do have a method of sending referrals to us. We do see a lot of Ochsner patients. Our outpatient services are limited to University Medical Center for now, but we do see patients from all over the system as well as from Ochsner, and we even get some patients from the Lake that we do telemedicine visits with. We get a lot of Mississippi referrals. Right now, we are expanding into the Mississippi region so that we can start to see patients from Mississippi because it is such a dire need area for palliative.
Yeah, absolutely. Egg cryo, referrals. So we are not on the Epic system. I do have access to Epic. I operate at Baptist, at Toro, at EJ. So I do go into Epic every once in a while, but the most efficient way, so the folks at Children's typically reach out directly to my nurse manager, Wendy Dalferez. I can provide her email, but our website is pretty available, the Fertility Institute of New Orleans. But in fairness, Audubon Fertility, the Fertility Institute of New Orleans, Fertility Answers in Baton Rouge. We all play very well in the sandbox. Our mission is the same. Let's try and get as many patients through to get them taken care of. So any one of those three entities, we welcome the opportunity to see patients. So I think go the website, but then there is a way that you can refer as a provider directly, and it goes into our scheduler box, and then we call that patient the next day. And then our nursing team will work diligently to get records, and then we'll get the patient in either that day, the next day, or within the week, certainly. Yeah.
And if any questions pop up later, everybody knows how to find me, and I'll be happy to work with you guys. Thank you all so much for presenting, and thank you for attending.
person I've met so far.
He'll listen to F-bomb.
He will.
I can handle him very, I know how to deal with him.
Reagan, I felt so, I was like, Reagan, Sherry's like, me and Perry were like, we understand, you know, personalities.
She's seen me with him.
But Reagan was like,
I can
I can hear the headlights, I was like, oh God. He was like, F-bomb this, F-bomb that. I was like,
He's like, I have 7 minutes. I'm going to the airport. And Reagan's like, oh, do you want to reschedule? Because I have some slides to show. And he's like, oh, no, I can Tesla. It's just going to drive itself. Like, it's
he was
fine.
the passenger side, and the Tesla was driving itself. And he was talking to us.
I don't, does that win, or does
That
it
is-
win the urologist is on his treadmill with his shirt off with the entire, like, Pfizer leadership team? It's
that
Ty?
might
I don't
win.
know, I don't know. The Tesla's pretty dangerous.
But yeah, he does
You
not.
know anything?
I'm gonna come that way. I think he doesn't scare me. I will.
After
This
we
is
test
somebody's
this.
dad. Like, I feel awful, but bye. Sorry, sucks to be you. Leave it here, that's what happens. You want to try yours?
Yeah, sure.
He doesn't scare me. I've dealt with this con.
Yeah. Yeah. Ooh. Okay, wait. You can tell I don't normally do this anymore with these things.
Hopefully, it's going to be like super quick. You know, like I can pull that out on mine and put it in yours.
Okay, why am I struggling here? I'm glad we're doing this.
Wouldn't that be typical?
It's right here, right?
Yeah.
Remember that game as a kid where you have to put the shapes in the... There.
Oh, shoot.
Thank goodness.
Wouldn't it be typical that Pfizer would give us a computer that wouldn't adapt?
Exactly. Okay.
You're supposed to be in a hazard health system.
Yeah. I need to put do not disturb on here. Okay. Does that look? I need to put, hang on, I have on my
I
brightness.
think I'll just sit up here and then like grab the laptop when you go up.
Goodness, I put the brightness down so low that,
It looks good on the screen. Look on the screen.
okay, I just couldn't see. Okay. And I'll just display settings. It's got a little delay, it looks like.
You need to switch.
Well, I did.
Switch the displays.
I did.
Doesn't skip.
That's a really weird.
Just do slideshow from the beginning.
It's got a really slow delay.
It's still downloading, it looks like.
I probably should clean my screen. If
This
Dr.
is
John is
weird.
gonna use my computer. It looks like someone threw up on it. Sorry. If you just press slideshow, what would happen?
It's weird. Like
What's it
see,
doing on
you
your
see on my end?
Here, can I play?
Oh, there we go.
What'd you do?
Same thing I did, but it just she's got the magic
I
touch.
tell you what, I got some
She's
good
got it.
mojo today. So,
Okay, good. Then I can just talk right from here, and let's just go forward and see. Okay, looks like it's good.
do you want to try this?
A little bit bigger right here.
Or is that going to be many cards. Oh, we got trumped? Well, let's fix that.
Same here. Like, we try. Pfizer doesn't give you money.
We'll get there. We'll get there now because we'll have competitive updates.
And also, like, your team that helped make sure, some tangible stuff.
I see medical debt support, but then that's good for us. That's good for legislative. It's at the same time as this one. Medical debt is huge. I'm biometric test too.
Thank you. Awesome. Good luck finding one. Let us know if you do. I will. Thanks.
Yeah, I think you're right. Well, that's the thing. We were wondering, like, if people don't realize.
We're gonna have some fun. So we're gonna sharing our split computers, and then what's Sherry's demo? Bring your computer back and then you can.
Okay, I'm not on.
It's up.
Oh, okay.
Do you want to see?
And I'm not techy.
You want to play?
I do want to play.
So this is 4 bar factors. There's what's this? A red dotting thing. What? Is it backwards?
This way? Okay, so. Got it. Thank you. That's it. Upright. Dot thing. Yeah.
Pointer.
Well, that just makes, that kind of gives me a little, I like that.
Oh, you like it? You like it? It makes me
That
nervous.
makes right here.
Do you mind signing in for us? Thank you so much.
Okay, good. And this has, oh good, this has the slides on it, because earlier they didn't have it, and they kept staring.
chicken that way, slides are illegal is like crazy, so.
Oh.
So once Sherry goes.
Oh wait, can I, will I be able to look at this, or do I need to look at that? Like, this will be here?
Yes.
Okay.
It's just kind of small.
That's okay. Oh, that is small. I'll look up there. That's fine.
And it mine's even a little bigger on my computer, but it's still small. I wonder if I can make it bigger.
Can you, why don't you do slideshow? Is that slideshow?
It's like a little finicky. Our computers are.
I don't know anything about
possessed
it.
by-
I just want to be able to work it.
Yeah, you should be fine.
Okay, good.
It should be like really amazing.
No, I think it's good momentum going from
Yes.
that. And then I was saying in the paper last weekend, on all the health section, always read Health and Inspire first, not the Metro.
Should we go ahead and start? All right, guys. Yeah. Can y'all hear me? It's on? All right. Thank you guys so much for coming. We really appreciate this. This is going to be a very different session today. We're going to review some data, both internal data that Pfizer has shared with us, as well as data from a survey that we did not too long ago. And the idea behind this session is really the bulk of it is going to be brainstorming. We want to hear your ideas and discuss what we can do to sort of eliminate disparities in prostate cancer treatment across the state. And I think that once you see the data, maybe it'll be, hopefully it'll become clear of the challenge. So want to thank you for the champions. We have several health systems represented here. We're really happy. North Louisiana, Central Louisiana, South Louisiana, all represented. And we had a little steering committee, champions, who worked on this project. You can see them here. I won't necessarily go through them all, but many of them are in this room, and we appreciate it very much. As I think most of you heard during lunch, we talked about the Louisiana Cancer Endowment. It's our brand new nonprofit research arm, and this is really the first project that the endowment has tackled with funds from Pfizer. We have not made any grants yet, but doing projects like this is what's funding the money that will allow us to make grants in the future. This project is not really costing us anything, but we're still getting funds from Pfizer. So we appreciate it. We appreciate it very much. So our agenda today: a little introduction, a little goal setting, and then we're going to have some of our Sherry from Pfizer, who's going to discuss the Pfizer data, the survey results. Alexandra is going to discuss with us, and then Dr. Halbert is going to lead us in a little bit of a discussion about how to better align to close some of these gaps, and then finally at the end, Pfizer's going to do a little bit of an intervention fair, right? We call, and then they have a couple of different people who have different specialties who are going to kind of divide up amongst the room, and we can kind of talk with whomever we like. I think finance will be one, and maybe data will be another, and so on and so forth. So we'll explain that, and in the end, a call to action. What do we need to do to follow up to make sure that our patients are getting the best therapy that is humanly possible? So, goals and objectives. Tell me when it's my time to stop and hand it over here. Yeah, it'll be obvious. Okay, good. But obviously, I think our goals here is that we have higher incidence of prostate cancer in the state of Louisiana. We have higher mortality for prostate cancer in the state of Louisiana compared to the rest of the country, and our patients often have weaker access to care. So our goal is to identify barriers and provide solutions to reduce gaps in care that exist within the state of Louisiana. So timelines and next steps. We're going to do this exercise today. Eventually, there will be a virtual follow-up for anybody who's interested in attending. That's why we took the names and everything. We'd love to have you guys follow up with this. And then eventually, we will hope to pilot some of these ideas and be able to show whether some outcomes have changed. So with that, I'll hand it over to Sherry, and we'll go from there.
Quick computer change. Commercial medical firewall. Yeah. All right. Okay. Can you guys hear me okay? All right. My name is Sherry Flatt. I am a clinical pharmacist by training, born and raised here in New Orleans. I'm really excited to be a part of this. Just like you guys, this hits very close to home for me and for my family. Today, we're going to go over what we call at Pfizer Oncology as the Quality Care Insight Tool. And this is looking at treatment patterns for patients with metastatic castrate-sensitive prostate cancer. So it uses an IQVIA database, which is a claims database. So we're looking at retrospective descriptive analyses on treatment patterns in patients starting new treatment for MCSPC patients. And so we'll go through this pretty quickly in terms of the data source. So like I said, it's IQVIA. I'm sure you're familiar with that database. It covers around 18 million US cancer patients, 10,000 oncologists, data across all 50 states, with about a 60 to 85% capture rate. So we definitely do not claim to have a 100% capture rate, but we do use this to identify trends. This database started in 2012 and onward, and then the treatment pattern started in 2015. This does include data for Medicaid, commercial, and Medicare, as well as cash transactions. What this does not catch is clinical trial data, free drug programs, or any drug where a claim would not have been submitted for drug. This is the inclusion and exclusion criteria. So patients with at least one ICD-9 or 10 code for prostate cancer, then we look for a claim for treatment. So we use those drugs for the proxy to identify the patients. We also look for a metastatic diagnosis claim as well. And then we're looking at adult patients. And then we exclude any other diagnoses for any other cancers out of the data set. Again, that's just going through. These are the treatment categories, so you can see the drugs that we're looking at. So this is an above brand. We're not looking at any particular brand of drug. This is above brand for this disease state, so you can see those drugs that fall into the different buckets for NHT, and now we're calling it NHT, ARPI. We need to update our slides a little bit. And this is the patient funnel that kind of just illustrates what I just went through on how we get down to the patients in this data set. We can apply different filters to the data set, and that's what you'll see here. For the purposes today, we're going to be looking at national data as well as state level and then regional data. I do have the ability to get down to specific health system level, but we won't be showing that today. If you're interested in looking at your particular health system, I can do that in a follow-up appointment. So just we can talk after this and schedule some time, and you can look at your individual health system data. Talked about the limitations. Okay. So the results. So this is looking at national level MCSPC patients. This is all patients in the first line setting. So you can see the years down at the bottom, just to orient you to the slide. The years here, number of patients are at the top. So that's going to be your patient N. The yellow box is your NHT-based therapy. The salmon is first generation anti-androgen therapy. The blue, LHRH monotherapy, and then you can see chemotherapy in the gray, and then NHT plus chemotherapy in the light blue. So for national, you could see about 47% of patients in the year 2025. Now this data is about half of the year 2025, so it's not a full year. The data set runs a little behind. But you could see 47% of patients are being treated to guidelines, because we know that treatment intensification early is now the standard of care. So 47% nationally, but Louisiana is looking a little bit better than that at, and my eyes are getting bad, 57? 53? I need my glasses. So we look a little better than the national average, which is good. As you can see, there's other percentages. The LHRH monotherapy number is still way too high. Now, when we break it up and we look based upon med-onc and urology, you can see a difference here with 26% of patients being treated with NHT-based therapy versus 56%. And this is national, being treated with NHT-based therapy from a med-onc. Now, I do want to mention there is a limitation in the data. If a patient has a 90-day gap, so say they get placed on ADT, they don't get started on their NHT therapy for greater than 90 days, that is going to show, it's not going to show up here. It's going to show up as second line because they're assuming you waited 90 days, maybe they've progressed, and now they're on a subsequent therapy. So we realize that there could be patient coordination challenges that may preclude a patient from getting that NHT within 90 days. So just keep that in mind, that that is a limitation in the data. So this is national numbers. And then for Louisiana, you could see that that discrepancy is quite a bit larger. So we're looking at 62% LHRH monotherapy with patients being seen by or managed by urology versus 17% LHRH when patients are managed by a med-onc. And I think this ties in really nicely with the session Dr. Halbert led this morning, where we talked about just different social determinants, different challenges that we're having here between, multidisciplinary care, care coordination, and we know we still have work to do in this state. So hopefully this can open up some conversation on what we can do better. Now looking regionally, so this is the New Orleans and Metairie area. Really, not a huge discrepancy here. I would say doing really well. So both patients managed both in urology and med-onc, 77% urology, 85% on the med-onc side being placed on NHT-based therapy. If we look at Baton Rouge, and again, you can see the patient ends up here, so just also keep that in mind as well. We do see a little bit bigger of a discrepancy looking at in the Baton Rouge area. Lafayette. And again, here it's a small N over here on this side, so it looks like the majority of patients are being managed by urology in the Lafayette area. And then Shreveport. So definitely seeing a discrepancy between urology and med-onc. So what can we do to improve that? And then looking at patients managed in the urban setting versus rural setting. So Dr. Halbert also touched on this in his talk. So you could see 57% of patients managed in the urban setting on NHT-based therapy, and a smaller percentage patients in the rural community being placed on guideline concordant care, 35%. And then lastly, looking at Medicare versus third party, we know that 50 to 60% of patients in the state of Louisiana are on Medicare or Medicaid. So very important for us to take a look at this to see if there's any discrepancies here. And I was happy to see that there wasn't a huge difference, although we know we still could improve across the board. And then lastly, everybody was putting in their Mardi Gras pictures, and so I thought I would throw in some Mardi Gras pictures as well of my kids and I at Iris and Tux, and they were very excited. They got a decorated plunger from Tux. They bartered for that and worked very hard. So yeah, I don't know if we want to take questions or any questions about the data before we move into the survey results, or any initial thoughts. It's when the claim is captured. So dispense, yeah.
It's tricky because you see people with a diagnosis of prostate cancer, it's just in the chart, they don't know where it came from. And it gets carried forward. Sometimes they don't know what the data is. Sometimes the medical records kind of flawed.
Yeah, and we definitely know that we don't have 100% accuracy in the data capture. I think, we just use this to look for trends.
So is it a way that you could, if you could take an individual institution and go through the cancer registry and then tie that to that medical record, then you could probably get something better. And especially if you were looking hard, you could probably get somebody at the institution to actually reconcile those things.
100%. We can definitely work. When we have in the past, we know that this data is not perfect. It's always better to look at your own data. And Pfizer talk and get those patients where they need to be.
Go back to that Louisiana urology and that outside one slide, a couple slides before. Yeah, so basically, what I'm getting from this is in 2025, the majority of patients who were managed by urology got just monotherapy, as opposed to the majority of patients followed by med-onc did not. So I mean, I think one way to look at that is kind of irrespective of whether or not the patient had access to it, it's still, you know, the numbers are still dramatically different.
Right. It's not national. No, not that we capture in a tool like this, but we definitely heard that it would be nice to be able to see some of that data.
Did you get from the cancer registry all the data or
No, this is
individually?
This is from IQVIA, which is a claims database.
I'm a nuclear oncologist. You mentioned radium. You didn't, I think 2025 till that. We started using Provecto. So it's not there that.
Yeah, no, that's a good point.
I think the greater question is, why is a patient with metastatic disease still being solely managed by urology?
But we talked about sensitive. I mean, Provecto is more for resistant, castrate resistant. So
And
that's
we
why.
do have data looking at castrate resistance, so if you're interested in seeing it, you can look at that.
I'm interested in knowing who is that 25% of urologists that is giving, or what's different about them?
Yeah, and I mean, again, like, you know, when you're looking at New Orleans metro area, it's doing really well. So it's like, how can we learn from the folks here and then, you know, spread that throughout the state? So we can take some good learnings from these folks. So that's part of why we want to do this, so that we can share ideas. So I'll pass it over to Alexandra. Yeah, I'll get you hooked back up, yes. Again, it's like silly medical.
He's got some.
Oh, wait a minute. Oh, yeah, this is it. I'm like, wait. Okay, here you go.
Thank you, and then, all right. All right, good afternoon. My name is Alexandra Kohler. I am a nurse practitioner at Ochsner, practicing in GU Medical Oncology. And I'm going to go through the survey results. We sent out a survey to, I think, roughly 25 respondents to MDs and APPs who practice in GU and treat advanced prostate cancer. The idea is to identify barriers in adherence to guideline-based treatment for advanced prostate cancer. So I'm just going to kind of run, not quickly, but through the demographics of who was surveyed. About 2/3 was medical oncology, 1/3 was urology. We had a mix, 84% physicians, 16% APPs. Years in practice, there was a wide range, but about the average was 17. Some were on the low end, some were upwards to 40 years. Male and female breakdown. Primary practice location, most said New Orleans and the surrounding metro areas. Some listed the institution in which they practice. This breaks it down between academic and private community practice, which I think will filter in a lot on that timely referral to MedOnc if you're a private standing urology clinic and maybe don't have those resources or access to get them in with MedOnc. That may make it difficult. Now we're going to kind of go through the questions about adherence to guideline-based therapy. First one is about understanding when and who to order somatic-based testing on. Most people did answer very confident or confident on ordering the tumor-based testing. When asked about germline or hereditary testing, same. Most answered very confident or confident, and we know that's in the NCCN guidelines to have anyone with advanced or metastatic prostate cancer tested. When asked about how comfortable you are in treating first-line metastatic castrate-sensitive, again, most said very confident or confident. And we talked about the use of PARPs, and this is when you kind of start to see that neutral and an unconfident come up a lot more. If this is maybe not med-onc answering and more urology, it's just not used in their practice. And we asked a follow-up to these questions. If you are not confident with the first-line treatment for PARPs, why? Most either said there's a clinical knowledge gap or not enough education on it, access, or they rely on med-onc to prescribe it. Treatment intensification with ARPIs. Kind of a mix too. Most said very confident or confident, but again, neutral said 13%, 5% for unconfident. So scaling up when patients progress. I mean, if they're progressing, they should ideally be referred out if it's on monotherapy. And if you're not confident, explain why. Most people said they were confident. For castrate sensitive, very confident and confident in treating. And we just talked about this in our prior lecture with radiopharmaceuticals and theranostics. Around 20% said neutral or unconfident, so there's a knowledge gap there, certainly for education on the provider and the patient too. Most providers said that they do feel their patients are on guideline-based regimens. Challenges that are faced in implementing those, most of it, as you can see the pie graph right there, was financial, whether the patient cannot afford the drug or having issues getting access to the drug, insurance issues, care coordination, helping to get the drug to the patient too, having the resources to do that, working with pharma companies. Biggest challenges, again, financial eats up most of it, and care coordination, and patient education. And this ties into what Dr. Halbert was talking about, what percentage of your patients are underrepresented minorities, and I think especially in Louisiana, it's most, if not all, of your patients. And what role do you feel environmental pollution may play? And pretty much everyone said a significant, if not large role. And we could look at two communities that have high incidences of prostate cancer and where are they close to, respective of these chemical plants. And then what are one or two changes that would improve patient care in your practice or region? Most are coming down to finances or insurance, and almost a quarter were timely referrals and care coordination and getting the patients over when they need to be seen. Okay. Questions? Thank you. Mm-hmm. And now, Dr. Halbert.
No, this is great. I think, yeah, so this is the first that I'm seeing this data. But I think that's good because I think we can get some good reactions here and think about where some of these care discrepancies are and what we can do for it. I think the first thing I want to do is probably just address one of the questions that I think we're all probably looking at in the room, which is, how do you get that denominator in that first data from the Pfizer data set? And yeah, I mean, there's going to be problems with capture, right? I mean, I think you could probably think about, patients within urology having this kind of misregistering them as having, metastatic prostate cancer through some sort of quibbles with ICD. And that's certainly going to drive things to some degree. But that's pretty darn stark data that we're seeing there. And I think regardless of, whatever kind of misregistration you have with that denominator, there's a real problem here, right? This is clearly an unmet need that is still going on within our system. And particularly interesting to me was looking at, dividing out the different regions within the urology practices. I'm really proud of our New Orleans urologists. It looks like they were doing a really good job. And I don't know necessarily why we would be misregistering patients from a New Orleans urologist more than we would be misregistering a patient from a Baton Rouge or a Shreveport urologist. So I think that really does point to some real differences in the care patterns between the communities in our state. I think it's also clear that there are real differences in the care patterns within our state. New Orleans is very much a city of integrated health systems. Whether you're at LSU or LCMC or Tulane or Ochsner, we're well integrated systems. I think you see that breakdown in Baton Rouge to a bit. It seems to me that there's certainly more private surgical practices within the Baton Rouge market, and I think that's exactly what you're seeing in that data there. And I'm also pretty sure, although I don't know exactly how we decided, the uptake of the survey, but my suspicion is that not a lot of the urologists from the LUGPAs were responding to that survey. A couple of other thoughts that I had here, and then I think I probably want to kind of open this up onto some other questions, and we can probably just discuss this ad nauseum for a while. So 53% above are having intensified therapy. That's better than the national average, and I don't know if I'm still allowed to curse here or not, but I typed in my phone, that's still a shit sandwich. So my apologies if this is being recorded for family use. No, obviously, I think regardless of what you think, this is still going to be a need that we need to address. And I talked about it on that first slide. We need to optimize care upstream of radioligand therapy, right? Couple of other gaps here that we mentioned the possibility that maybe urologists are getting patients onto these medications. It's just taking them more than 90 days. I think that's possible, especially if they're referring out to a medical oncologist and it's taking time to get into medical oncology and get that back. 90 days is still a long time. Like, that's plenty of time to get your patient onto appropriate treatment. And so I'm not sure if I buy that as an adequate response or not. I'm kind of proud for, difference in payer mix is good. I think that kind of shows that maybe at least, our public payer system is at least working and not giving too much of a pushback. If we clearly saw that Louisiana Medicaid was not paying for intensified therapy while, Blue Cross Blue Shield was, I think that'd be something we could address. It doesn't really look like that. I think I talked about the integrated health systems. A couple of things that I'm really interested in here that we didn't address here. The role of the specialty pharmacy. I think that's critically important. And part of why I was asking a little bit earlier too is this data being captured whenever the drug is dispensed, or is it being captured, at the time that a doctor is prescribing the medication? We don't know that. We don't know how many of these patients are actually getting the drug prescribed and then it's never getting dispensed, right? And I'm really interested in the role of the specialty pharmacy in getting patients on a drug, because it seems like it's, they make money when they dispense a drug, so it's in their business model to actually make sure that they fill the prescriptions. But I do wonder, I love our specialty pharmacy, and I think most of the integrated health systems have their own specialty pharmacies that they probably love, right? I know the pharmacists there. They can message me in Epic whenever there's an issue with a prior authorization or a patient getting filled. It's seamless. And I know what's going on with my patients who are not getting their drug filled, or that are getting their drug filled through, our specialty pharmacy. Whenever it's being pushed out to a different, an outside specialty pharmacy, it's a black box for me. And that is a critical area that I think you're going to see a lot of leakage in this setting. So that was my thoughts on specialty pharmacies, integrated health systems. Again, I don't want to harp too much on the urologists, because I think they have a tough job. And by definition, if they refer a patient to a medical oncologist to manage their care and they show up, that patient is probably going to be a little bit more compliant than a patient who might have showed up one time in a urologist's office, got a diagnosis of metastatic prostate cancer, and never reappeared ever again. You know, by the fact that they made it to the medical oncologist clinic, I think that gives you a sense as to that they're more likely by their nature to get their drug filled. So I think that could be a little bit of what's going on. So I think we'd probably want to see a little bit of where that leakage is. And I think the idea of really, you know, I would really like to see if we could fund a larger scale, you know, survey that we could really get not just the folks within the integrated health system, but really get into the LUGPAs. I mean, I like, let's just be honest. I think that's the elephant in the room, right? Is you know, how are we going to get the word out to these those large private practice groups, and make sure that they are giving people the drugs that they need? So the way I see it is we need to figure out where the leakage is, right? And if we can take this data and make a little process map, and we could sit down and do it, and like, look, where is the process map of the patients getting diagnosed? Do they ever show up again? Or do you say, or does somebody tell, a urologist tells them in the hospital they have metastatic prostate cancer, and they just never come back again? You're gonna have some leakage there. You're gonna have some leakage from patients who maybe they see their urologist and they get referred to medical oncology and the referral falls through the ropes, you know, and we gotta see where that is. I only see the patients that I see. I don't know the patients that I don't see. I think we need to see how many of them are getting prescriptions, but not getting those prescriptions filled. Because that happens every day in my practice. I write a prescription for novel ARPI of choice, and I tell the patient to come back in 6 weeks or whatever and see how they're doing on it. Say, how are you doing on your drug? And they say, I didn't get it. And you're like, why are you here? You know? I mean, it's good that you're here. Now I can kind of push the button again and try to get you back on it. So I think probably the next steps here would really be to take an idea of making a process map and figuring out where we see the leakage that's explaining this data. Thoughts? Yes?
Do you feel that the urologist is to blame for instead of lack of knowledge or lack of ability to get the specialist either in both areas?
I think them not having the benefit of my specialty pharmacists is a huge deal. I don't do prior authorizations. You know, I have somebody that does that for me, and I think a lot of the people sitting in this room do that. And yeah, if I'm a private practice urologist, I imagine that's a huge barrier, which is probably, you know, something that we need to think about if we're gonna get a better, you know, a larger survey to really find these barriers, really make sure that we're getting into those practices and finding out where their barriers are.
So, and we just recently, Lady Lake just recently acquired one of the big urology groups.
Good.
And
Good.
And as a rule, the urologists have kept patients longer than they should have. They put them on Lumon and not treated them. And I'm not surprised that they, by this data. Now, I think there's a way to affect that, at least to where we are, by bringing the guidelines, presenting this data, and then telling them, look, New Orleans does great, you know. And I think that would change, and then making it clear that they have access to pharmacy.
Yeah.
And I think just explaining what's going on, explaining the process, I think will change a lot of behavior. And I think if you did that and you made that work and changed that, then you can bring that to the rest of the private oncologists and tell them what's happening.
In your experience,
Affect the whole community.
I'd be curious, in your experience dealing with some of these urologists, you get the sense it's just a knowledge gap. They just are unaware of, yeah. But you see it? I mean, that's good to know, because if it,
It's typically how long longer and
yeah,
not necessarily dealt with the changes. Now,
yeah.
prostate cancer's been in the past kind of hard to follow because you hear this story and you get, things don't always match up. And so it's, you could argue that some of that was okay, but nowadays I think double therapy should be given. And if it's not given, then that's inappropriate and ought to be addressed.
Yeah. No. Do you give, whenever on the occasion that you get a patient who's been managed by urology, for a period of time, and it's clearly a urologist who likes to hold on to their patients, who's giving them their Lupron? Are you giving them their Lupron, or are you letting urologists do it?
Sometimes it's them, but more times it's them.
Yeah.
Is that financial? Is it financial?
Well, I mean, I think it used to be, but
Yeah.
now that you've got a practice that's been assumed by healthcare, I mean, it seems like that incentive would go away that you still part of the umbrella of the system, right?
Yeah.
Right. I mean, it's new, but like we just had a meeting with these guys, and we had this health, industry company come in and like present this to try to foster a conversation about it with referral men and there was nothing from these guys in terms of medical policy.
Hmm.
Yeah.
I'm not a, specialist in urology, average patients. And, of course, prostate cancer changed dramatically since I finished my fellowship in 1984. But, in terms of the coding, you showed us a study where the patient had metastatic castrate-sensitive carcinoma prostate. So in our clinic, I work with fellows, they always put the wrong codes. But, so when I look up the ICD-10, you got one code for prostate cancer, C61. Okay, then you to say that it's hormones castrate sensitive resistant, you got to do Z19.1 or Z19.2. And then to say that it's metastatic, you have to add C79.51. So, I mean, I'll be honest, I'm guilty. I would never do that many codes because I'm not just a prostate cancer doctor. If I had a prostate cancer specific billing sheet or panel on Epic, maybe I would do that. I wonder how accurate that information is on how those patients are categorized. Because to say they're metastatic by the old criteria, they have to have a positive understanding or a positive CAT scan, so you have to have this C79.51 code. And really, do the urologists even do that? No, I mean, I don't. I know. Does everyone here code appropriately? If you have a patient in that category, you put all three of those codes? You put it while you're seeing the patient?
I'll put the liver, and then there's a code for lymph node, and you go.
For your
Yeah.
regional multi-site.
Yeah.
You have to connect it to the prescription you send electronically.
Alexander runs they work in our advanced prostate cancer clinic that's operating at a much higher level than the average.
I would also say we have a whole suite of people who make sure we code appropriately for reimbursement.
I wouldn't expect them to know what, novel anti-androgen prescription, just like they shouldn't expect me to do intravesical BCG.
Yeah.
That's where I'm having like conceptual problem is like, where do we kind of educate that you don't have to do this? There are other people who do. I don't know, maybe it's a private practice billing thing. I don't know. I hate to put it that way, but.
Maybe putting like a clinical pathway together that if the patient falls within a favorable versus unfavorable, what line should the referral then place? And have that in place so you can then spread that to the rural areas, to other systems. If it's working for us, if it's working for you, that way it's black and white.
I mean, I do think disseminating best practices is going to be important, sure.
I have two thoughts, and just want to get y'all's ideas on this. If urologists don't want to give up to the patients, is there a role for tertiary centers to do like a one-time virtual consult, just to go through a checklist? Or, would you have, you hand this checklist to urologists and say, these are all the things the guidelines say you should be doing?
I think if you bring it to the attention of the practice manager, it'll change.
Really?
If you bring it to the attention, this is the standard, this is how often you're meeting the standard. I think the practice manager is gonna have to do something, say at least do something about it. If it doesn't, then the practice manager's boss might do something about it.
So it's all Mark's fault. I'm going to pick up two threads here. One, I think there was some discussion there about the methodology on getting the Pfizer data there. I want to clarify here. It looked to me like it was like two C61 codes, and then how were you guys actually using those Z codes, or? Because usually, it'd usually be like two C61s, and then to determine if it's like castrate sensitive or not, you can look back in time and see if they've ever had Lupron before, or another ADT agent. So you're not relying on the metastatic, code, but just by the fact that they all of a sudden have a prostate cancer diagnosis and they're getting Lupron for the first time, you can presume that it's castrate sensitive. And then oftentimes, you might still be able to pick up a secondary malignancy code, like a C67 code, pretty easily. But that would get outside of the Z codes, which I think are a big issue. I doubt those are getting captured very much. The second thread I was going to talk on, I really liked what Dr. Matrana just said. And this is something that's been kind of like poking in my head around a little bit. Because when I first came to Ochsner, I think my entire goal was like, well, I'll just see every single prostate cancer patient in the state of Louisiana. And, I can see 80 patients a week. There's a hard cap on what any one of us can do, right? But how is it that we think about different models of care to bring some of this best guideline concordant care out there? And, some of the capabilities that we have now, and reimbursement is a whole different issue, but when you think about, virtual visits, or you think about things that we do, like e-consults even, would be a really interesting thing to do, especially if you could open them up maybe even outside of the tertiary care center, and you could, review a patient case and either do a virtual consult with that patient or just give, kind of off-the-cuff recommendations from an e-consult perspective. I would be really open to the idea of saying, look, I take a half a day a week and I just do e-consults or, like those sorts of one-off second opinions where I'm not going to be taking care of the patient.
Is there a way you could speed that up with AI or templates?
I don't know.
I'm sure you can embed it into the EMR and bring up the thing and say, hey, this guy has metastatic prostate cancer, would you consider?
Yeah.
I'm sure you can do that in each system. That's going to take some time and some compliance on the part of the IT. But I'm sure you can. But that would still come from the urologist, so it would take.
Yeah, you got to rely on the urologist to actually do an e-consult or something. Yeah, thinking about like a BPA that you could put into the. Do any of you guys have a BPA like that in your Epic? Yeah, in your EHR? Yeah, I mean BPA fatigue is real.
We've seen some practices make recommendations off the path report, off the biopsy.
Where like the pathologist says, by the way, I recommend you give this guy some enzalutamide.
About the clinic themselves, like if we see this, then we're going to do this.
Okay.
So let's put that reminder in the path report.
Yeah. Yeah, you have a biopsy from 1997, and you have a PSA level of 40, and you have a PET scan or a CT scan. Yeah.
I'm seeing that high risk patients right now.
What about the AI? What about using AI to risk stratify for a handful of patients? Maybe that he's not right.
So you just need one of these? C79, C77, C78. Okay. Which is probably capturing. I mean, the urologists are probably not very good at coding. We code a lot of C79 because literally, I mean, they track it. And once every quarter, I have a meeting with billing specialist who's like, well, I was looking through your charts and you have $5,000 on the table by not putting C79 on this patient.
Right.
They're not doing that. So we're good at capturing. So that might be some of the. I think we need to find out where the leakage is.
Yeah, I agree.
Well, no, I mean, I think it does. It goes down to it. We need to get the opinion of the community and the private practice urologists, and we need to find a way.
Like I'm mostly at UMC, but the one day a week I need to go to a rural clinic. I mean, it's a dramatic difference in who's referring. I mean, at UMC, like 90% of my clinic is prostate
Yeah.
referred by urology. Up in the rural area, it's like way less than that because they're all being managed by urologists.
So how do we get them in the room?
The patients I see are ones who are progressing after being
Yeah.
on, treatment from urology, and then they're like, well, we don't know what else to do.
But how do we get the urologists in a room like this? Yeah.
One thing we're working on with the Louisiana Urological Society, that's always helped me with this, is getting this data to that society of urologists to see what's happening.
Yeah.
They have an annual meeting every year,
I mean, shame is a powerful tool.
Well, there's definitely a care coordination issue. We're seeing this also with bladder as well, with these new products in bladder, urology, oncology, bacteriology again, or whatever. And so there's also a lot of different issues with care coordination. We realize that. And hopefully, with you guys' help, we can help solve some of those issues. So thanks.
We do have people at Pfizer that are Six Sigma patient journey mappers. So I just wanted to make sure, like Michael can show you some examples if you wanted someone to sit down with a practice and map through their current state and workflows. We have people that have been trained to do that.
I mean, I think that really is important to see, like, where that drop-off is. And, I mean, I think about it in my own practice, too, because, like, I know I have patients that I'm prescribing drug to that aren't getting drug. Now, hopefully it's minimized, but, I would be curious to see where that fall-off happens. Or just loss to follow-up is a big one. I do think there is something, too. The guys that get diagnosed with metastatic prostate cancer, they're just never going to show back up in clinic again. Maybe they got one dose of ADT because somebody held them down. But, like, how much is that happening? We just don't know. Yeah.
So I'm a nurse practitioner that I just moved from Boston, so
Oh.
I take care of prostate. But you got, with the AI that you have presented there, you were talking about clinical trial matching and things like that. That same tool could be utilized to identify metastatic patients at any time during
Yeah, you're talking about like these third-party vendors, like using like Trial Library or Paradigm. I think like those sorts of things.
that could identify them that with already if they're already utilized.
I think that's a good idea.
In the system, I've got a very bad system. One thing that's very irritating is it keeps flagging the same patients over and over again that need a social worker.
Oh God. Patient declined. Patient declined. You can't. I'm not even in the patient's room. Yeah, BPA fatigue is a real thing.
Because it's such an aggravation.
I agree with you on that. I do worry that, I think too often we think that a BPA is going to be a fix-all.
I agree too. Because it shouldn't be a hard thing.
I have to lie every time it pops up.
I started doing that. I actually would start to refer those patients, and my social worker got mad. She was like, how many do you think there are of me?
Well, I do like this idea of the urological association. That might be a good idea to disseminate this in a while.
So, yeah, but here's the question.
Yeah.
How many of the urologists participate in the urology?
You might be all the academic guys.
Yeah, it's the guys that are prescribing.
Yeah.
They have the southeast AUA is this weekend.
Yeah, right.
Mm-hmm.
It's just fascinating to me because they are a surgeon by profession. So I often wonder, like, what is the surgeons want to operate? So what is really your incentive of seeing someone? You know what I mean? Like, I
Well, I mean, traditionally, I think we all thought that it was financial, right?
What is the reimbursement for Lupron versus a surgical procedure? It can't be comparable.
Yeah.
For a general urologist, you have a repeating visit every 6 months, each practice in town. Originally they got, when it first started, in order to replace orchiectomy, they had to pull a little trick where they got $100 per month's worth of Lupron. And that's caused a huge shift because everyone was getting orchiectomies in 1981, but by 1985, everyone was on Lupron. And it was financial underpinnings of community urologists to have 40 or so of these chronic patients, traditionally was low grade prostate cancer. But it's still, they develop all sorts of, they develop lower urinary tract obstruction symptoms. And so they're the chronic patients of urologists. So every 6 months, they get to talk to them, see about their symptoms. And it stabilizes their practice. I'm not saying they're doing it for money. They're doing it because it stabilizes their practice.
Do you think that I mean, if there's these kind of historical underpinnings of, urologists wanting to boost up their own practice, maybe get, some financial reimbursement from the Lupron, that's becoming less and less of a thing now as they're kind of being bought up. It's probably less. But, there's probably just some historical, memory imprinted in there, right? I mean, do we know if we see a divide by the age of the urologist? And I hate to bring age into everything here, but it does seem like, I mean, anecdotally, it does kind of seem like the younger urologists don't seem as interested in giving Lupron. And they seem more interested in getting their patients to me. I wonder if, I wonder how much that's driving it as well too. And maybe we will continue to see some improvements there as things age on. But yep. Yeah.
And you make a good point. It is habit. It is that muscle memory
Yeah.
of holding on to these patients because it used to be a revenue source. But the economics have changed a little bit, and I do think I'm confident that's going to get better over time as we move forward. And you do get a younger urologist in the practice, but it's going to take a little bit of time, and there is an education piece as well, whereas some of the senior urologists still think Casodex is appropriate, and I think the AUA guidelines need to be updated as well to reflect certain practices that the oncologists are doing. So it's a whole host of issues. I think one of the things that we're trying to do is educate, and as Michael said, we're going to meet with the LUS board and hopefully provide data to them to sort of champion this cause. The challenge is sometimes the urologists that are present there aren't really the ones treating
Yeah.
prostate, right? So it's so fragmented, it's hard to narrow down who's actually getting the prostate patients. So I think we're moving in the right direction with this sort of organization, but we got some work to do.
Well, and certainly, we can't just kind of close our eyes and hope that as the things age, that things will eventually get better over time, because that doesn't help the guys who are undertreated today. And those are real lives that are being affected that we owe to try to get them the best care they can too.
This is a little maybe too pushy competitive, but maybe we should take this data, summarize this data, and send it out, and say we suggest that guidelines be followed. Perhaps something like that, so if urologists actually get the data, something pointed out to them that is not.
It may also be good if they realize that they weren't losing money while it goes. I mean, if you show lack of profit, that may be another lever. If the realization is this is what it used to be, I don't really need it.
I mean, it's in the financial interest of the specialty pharmacies to fill drug, right? And so, you know, it's like I was saying, it's a little bit of a black box when it's going through a specialty pharmacy that isn't my own, but I suspect that, you know, they are financially incentivized to make sure that they can get more prescriptions as well, too. So I imagine if you talk to the CenterWell or an Optum or something like that, they'd probably be okay with figuring out ways to get more prescriptions their way. Yeah. 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 You know, and if you could get that same level of, you know, white glove service to these folks in you know, the community urology practices, they'd probably be a lot more likely to write some ARPI. But yeah, I don't know how you do that. You can't necessarily do it strictly through the specialty pharmacy because you don't know which specialty pharmacy the patient's going to have to go through, right? I don't know if the payers could, you know, like, you know, have some sort of, you know, better patient navigation within the insurance payer side of things. I mean, I'd hate to ask the insurance companies to do anything for their patients, you know, but they at least know who would be trying to fill the drug. Yeah, I don't know. It's a tough position. They probably just need to have a coordination amongst the variety of the different specialty pharmacies and then have some training so that you could train up staff members within the local urology practice to take on that ownership. But yeah, I mean, that's capital investment that they got to take. What do you got, Tully?
One thing I was going to say, I know we kind of mentioned this a little bit, but if we really can identify a urology champion, that would be paramount. I know Dr. Mutter sits on the CAGLA Scientific Board. Dr. Yes, absolutely. So if we can get someone like that, maybe a couple of them, that can really disseminate the information and the conversations that we're having, that can go a long way because all of those guys that I just talked about are part of the LUS. They have captive audiences, so I think that would be extremely
Actually, yeah, I think we got to get somebody from Baton Rouge for that. Because I mean, Baton Rouge is like the thorn in the side here. I think. Where I mean, you saw that data. I mean, yeah. And I mean, Baton Rouge is a big market. It's going to be bigger than the New Orleans market moving soon. You know, the way the demographics of the state are working. Tully, I'm curious because I think like you mentioned, you have the unique position out of probably anybody in this room of really getting into the urology clinics across the state. I mean, so what has your experience been with your calls on some of these, smaller, or, these private practice urologists that may not be having the uptake? You know, what do you see? Do you get pushback? Do you see, is it a lack of knowledge or is it like a lack of time? Is it a lack of?
Yeah, I think some of them don't want to deal with it.
Yeah.
But yet they kind of need those patients to help with their practice. So I think those are some challenges too because they really don't want to treat it, but yet they want to hold on to them and those patients fall through the cracks. There's that education component some of them will tell you, when I had conversations about my products, they were like, oh yeah, we don't refer them to oncology. And I just don't think that always happens. 'Cause when I talk to an oncologist in that community,
Yeah,
they're
they
like,
don't
we're
get
not
it.
getting them. So
Do you think the AUA would get through to them?
I think that would help, because that's a different food source. That's their community, right? I think that would be beneficial, and I don't know why the AUA drags their feet on some of these issues.
I think if we can generate a summary of this discussion, I can get it to the practice managers, and I think that alone will make an impact.
Yeah.
Well, they need to see the data.
Yeah.
The data needs to be shown.
Yeah.
Because I think just looking at the difference between Baton Rouge and New Orleans is gonna, I mean, suppose you were working in New Orleans and you saw Baton Rouge was way better than you, that would
I'd be
not like that.
shame.
Is this something that we should publish online?
And I think the timing of this is really key too. Michael mentioned this earlier, but like penetrating into the urology space, because again, I know this is prostate focused, but bladder landscape is shifting fast.
Oh yeah, you guys want to talk about PD-1 and non-muscle invasive?
So again,
That's a whole different,
that whole education and awareness within the bladder space, because they're already hearing about LUGPAs potentially giving medications in the bladder setting that scare me. And so I think this is really timely, because the landscape is just drastically shifting, and if we can pull a urology group together to talk through this.
Patient education is important too. I've definitely got patients in the rural clinic who are very skeptical, like, why do I need to come see you? I've been seeing Dr. So-and-so for years, and I've been wrong.
Yeah.
Why do I need to? And so it's that kind of mindset of, well, this is a different type of reason that you're seeing.
And I mean, that comes back to some of that leakage earlier too. I mean, like maybe you can get it. Maybe they are referring patients to medical oncology, and they're just not showing up. You know.
Can MISEP do an educational symposium inviting urologists and local Louisiana? And the guidelines and CCN and especially rural physicians.
virtual options so that people
Oh, for
can,
sure.
yeah.
We're doing that.
It's like, you know how the standards go.
Yeah,
One
no,
year
it's
it's
not.
like,
They historically don't turn out.
like, how many people are here?
I mean, it's really hard to get them to show up.
But they're the practice managers.
Listen, if you're restricted to doing label talks, you're not gonna educate people. It's like
It's
you
so
said,
true.
you had to go in there and tell them all the side effects.
Yeah.
That's what's in the label.
Right.
It's not general education.
We have the ability, like this deck was created by Pfizer. We have the ability, there's part of Pfizer is non-branded. Our job is to grow markets and set conditions for success for the brands. So when this group, and Sherry's part of it, when we get together, we talk about improving guideline concordant care. So we can absolutely have a presentation with urology, practice managers, oncology together to talk about guideline concordant care and never mention a drug name, so never talk about a label.
We can do that at dinner time also. Get a group together, insights meeting, we can do that as well.
They take really practice or practice.
That's fine.
I would tell you, nobody does that up in Shreveport area, all over. Except if they bring them in that center. Then we can have non-label talk. Otherwise, it's label.
What
Yeah.
have you educated the patient advocates for prostate cancer about this?
Like, give me get the patient advocates
About
involved.
the disparity,
Yeah.
and, about that this is an issue.
Yeah. I mean, I think you probably could bring. I mean, I think you could probably bring this to men's health events and go to your community centers and your community awareness fairs and probably education and educate the community specifically. And I mean, it might be striking to some of these community groups to say, hey, XYZ Church here in Baton Rouge, Louisiana, y'all are getting substandard care. Might light a fire underneath them. if we think about ways to make urology, to help urologists prescribe more guideline-conforming care, you either have to do one of two things. You have to give them an incentive to do it, or you at least have to make it less painful to do it, right? If you don't do either of those, they're not going to do it. So, outside of, financial incentives, well, I guess we can't have them all build out their own dispensaries, but if they do it, they do a good job, right? If we're going to remove pain points, it's probably figuring out ways that we can help them build out staff to get this working. Is there a way to lower prior authorization requirements for the
I mean, are you really solving anything if we continue to allow them to treat? Because as your paradigms change, it's going to become more and more medical oncology needs to be involved.
I think probably the role of the integrated health systems is probably to make it more and more of an expectation that these patients will be managed within the medical oncology clinics. And so I think as we, kind of get more vertically integrated, we can probably do that. Now, I can't really force a private practice urologist to do it.
No, but you can show where you might not be doing the right thing.
Yeah, we show them how much goes into managing an APC patient, like bone health, cardiovascular, diabetes, like all the things we manage in the APC clinic, all the side effects of the drugs. Instead of just prescribing it easy, but monitoring it after.
But can I ask why do we need a prior authorization for the C601?
That insurance company,
Yeah, but why?
True.
I mean, they're a regulated industry. There you go, Mike. That's next year's legislative agenda. Prior authorization.
I can't assume Public service announcement. Your prosecutor.
Great, you know, your next one's due now, and I've written
let's say